So first of all, welcome everybody. Welcome to the new interns, to our departing interns, and our returns. This is always a very exciting day. We're always very sad to see people go, but we know they're going on to continue their professional development and stay as part of the vortex, committed to making medicine better, to making clinical trials reflect the care we want to give in the future and make sure that the care we give in the future is based on quality evidence, innovation, biology, and patient preference. So that is, of course, our whole task. I want to also welcome all of our mentors and all the people without whom your years would not be so great. We are so lucky to have such a committed group of faculty, such a committed group of our administrative staff. I want to particularly thank Francesca de las Alas, formerly known as Prince. No, and so for being a fantastic manager of the program and keeping everyone on track. You all know that if you have any issues, that's where you go first. I want to also thank Jeff Belcora for training everybody and being sensitive to thinking about shared decision making and how you prepare for shared decision making and how everyone here learns how to listen. This is a unique opportunity that most physicians never get. And so you are learning, you have learned, and all of you will learn how to be an advocate for your patients instead of for your specialties. And that's the basis for all innovation. Hearing how what people think about the treatments we have to offer is very sobering. And it is very motivating to try and make things better. For all of the new interns, I think you will be absolutely amazed by all of these presentations from today, and it will inspire you. A year from now, this will be you. And you're going to be wondering, how am I going to do that? It's easy peasy. You will get there. Anyway, we are so excited to have this day. And then online, I don't know if Amy Babel is online, but Amy Babel is about 7 to 8 years into this program. She made the decision to endow the program so that we would have funds to hire an administrator to help manage the program as it grew. And it grew from like 4 or 5 people to now what it is today, to 16. So we're incredibly grateful to her. It's called the Amy Babel Leadership Program in honor of her father, who really believed that teaching people not only a skill set, but a leadership skill set was absolutely an essential part of training and education. And so that's really what we're focused on today. So every person who presents is going to start with the most important thing they learned this year. Don't forget. And then they're going to talk about their presentations. We have the day kind of organized from in a way that's comprehensive, starting with our complex trials, where we are addressing, where we're coming up with better solutions and better ways of trying to optimize care and individualize care, despite being in a randomized trial, to be able to figure out how do we anticipate how personalized medicine could be practiced and will be practiced, and sort of to gather that data and figure out how to do that. So without further ado, I'm going to invite both Alyssa Pama and Annabelle Duflock. They're going to tell you about the main trial, I-SPY 2. Oops, I remember I forgot to give you guys the slides. Anyway, that's fine. I'm sure you are very resourceful and got them anyway. And also to talk about our endocrine optimization pilot. So this is, again, for you new interns, the idea that, you know, breast cancer is a spectrum of disease. You're going to hear about that today. And it starts with, you know, you can have shoplifters to murderers, right? And so the idea is who's most at risk. You want to do different things for the people most at risk, and you want to where you're trying to get the treatment right. And for the people with the really minimal cancers, you want to try and avoid overtreatment. That's sort of the biggest thing. So Annabelle and Alyssa, please come on up. A little intro to each of these trials, and then you're going to hear each of their presentations. So.
Thanks, Laura. Okay. Good morning, everyone. My name is Alyssa Pama.
And my name's Annabelle Duflock.
And today we'll be talking about getting the right treatment to the right person at the right time. And we'll be giving a brief overview of the I-SPY 2.2 clinical trial and EOP trial.
Okay, so like Laura alluded to before, the I-SPY clinical trial really hinges on this idea of getting the right treatment to the right person at the right time, with the idea that not all breast cancers are the same, not even all breast cancers within one specific subtype. So the I-SPY clinical trial offers personalized breast cancer treatment options for women with clinically high risk stage 2 and 3 invasive breast cancer. And one really important tenet of the I-SPY trial is that clinically high risk does not always correspond with molecularly high risk. So Alyssa and I are going to explain how in the I-SPY trial, we actually have two separate trials. We have the main trial, which is for women who may really benefit from chemotherapy. And then we have the endocrine optimization pilot, or the EOP trial, which is for women who may not need chemotherapy to effectively treat their cancers. And the way we assess this molecular high risk is by an assay called the MammaPrint. And we use MammaPrint testing to give women a score. MammaPrint testing gives women a score of high risk 1, high risk 2, low risk, or ultra low risk. And then we go further from there to talk more about the response predictive subtypes.
And then to further classify patients, like Annabelle says, we classify them with the response predictive subtypes, or RPS for short. And this is based off of the standard breast cancer receptors, hormone positive or hormone negative hormone receptors, and HER2 receptors. And it considers additional features of patients, including their immune status, DNA repair deficiency, and blueprint status. Now, going into the specific I-SPY 2.2 main trial, it's a phase 2 clinical trial for MammaPrint high-risk patients. It uses a sequential multiple assignment randomized trial design, or SMART design, and the ultimate goal is to maximize the chance of each patient to reach pathologic complete response, or PCR for short. And that means that no invasive cancer is found at the point of surgery. The I-SPY 2.2 trial is split into 3 specific therapy blocks, block A, B, and C. And the general gist is that we start with experimental therapies, and then we move forward to standard of care therapies based off of a patient's response on treatment. Now, going more into how is I-SPY 2.2 using adaptive treatment. So talking first about early escalation, you can see at the top of the diagram that there's early escalation time points halfway through block A and block B. Using MRIs, we're allowed to assess how is the patient's tumor responding, and if the patient's tumor response isn't great or it's not responding to therapy, they're able to early escalate to the next block of treatment. And that allows them to not have to stay on the same treatment if they're not responding. And then there's also de-escalation time points, which is at the ends of block A or block B. And this allows patients to proceed to surgery early based off of their MRI response and biopsy response if they have a high likelihood of PCR. And doing this allows patients to avoid unnecessary toxicities that they might have experienced if they went through all 3 blocks of treatment.
So to sort of zoom out a little more on this idea of de-escalation, the I-SPY Endocrine Optimization Pilot, or EOP sub-study, really asks the question of, can we safely avoid giving chemotherapy to women who may not benefit from it? And can we instead treat them with neoadjuvant endocrine therapy? So we talked earlier about clinical high risk not always corresponding with molecular high risk. All of the patients on the I-SPY trial, both the main trial and EOP, are clinically high-risk breast cancer patients, but the EOP sub-study specifically focuses on those patients with lower molecular risk, so the women that are not in our highest risk groups. To take a big picture here, the EOP sub-study tests neoadjuvant endocrine therapy for early-stage hormone receptor-positive, HER2-negative breast cancer patients. These patients receive 6 months of endocrine therapy and then proceed to breast surgery. And premenopausal patients also receive ovarian function suppression to further limit their breast cancer, their estrogen production. Similarly to the main trial in the EOP sub-study, we assess response and gather information at various points throughout the trial. We have an MRI and a biopsy done at baseline, another MRI and biopsy done at the 3-week time point, and then 2 more MRIs at the 12-week and pre-surgery time points. So to take a big picture of the I-SPY 2.2 trial highlights both the EOP and main trial. The big picture here is that neoadjuvant therapy or pre-surgery treatment allows for assessing response to treatment in real time, and patient-centered design is key. We're able to tailor treatment based on response in this trial so that we can give more treatment to those who need it and less to those who do not, because quality of life really matters. To take another big picture, I-SPY improves options for women with early stage breast cancer, both while they're actively on the trial and hopefully in the years to come with all the things the I-SPY trial tests and discovers through each patient. And to sort of wrap up, we just wanted to show a big overview of all the different I-SPY sites that are currently enrolling patients. We have 46 sites activated, 28 main sites, and 18 satellite sites. These are all places patients can go around the country to receive care on the I-SPY clinical trial. Thanks so much for listening to our overview of I-SPY.
Thanks, Annabelle. Okay, I'm going to go straight into my intern presentation, and I want to start off with one thing that I learned this year, and that is that more treatment doesn't always mean better patient outcomes. And we learned that from the I-SPY 2.2 trial. So my project today is on the role of new treatment for hormone-positive patients after surgery. As we talked about in the I-SPY 2.2 trial, the screening phase and treatment phase is before surgery, or what we call the neoadjuvant setting. And then after, what we call the follow-up phase, which is after surgery, is the adjuvant setting. Today, I'll be focusing on the adjuvant setting for I-SPY 2.2 patients. The specific patient cohort that I looked into for I-SPY 2.2 patients is the hormone-positive, HER2-negative patients. I wanted to look into these patients because their risk of recurrence spans many years, and it can be decades. And that shows that there is a huge need to find optimal treatments that can reduce risk. And what really motivated this project is I worked with my mentor, Dr. Bacha Sharma, with one of the I-SPY 2.2 patients, and she was hormone positive, HER2 negative, and she received neoadjuvant chemoimmunotherapy on the trial, which isn't yet FDA approved for this subtype of breast cancer in the neoadjuvant setting. And we wanted to know what adjuvant treatments are these patients getting after receiving this novel chemoimmunotherapy, since a precedent hasn't been set. And we're especially curious in knowing if they received CDK4/6 inhibitors, which is cyclin-dependent kinases 4 and 6 inhibitors. How this drug works is that it forces cells into a resting state. So this means that cancer cells would be less likely to be in replication or spread. And it's especially effective for hormone-positive tumors because the estrogen signaling pathway is connected to the CDK4/6 cell signaling pathway. And what's interesting about this is that there is an FDA approval for use in this receptor subtype in the adjuvant setting, abemaciclib in 2021 and 2024, which is relatively recent. And since we're still testing chemoimmunotherapy in the neoadjuvant setting, we're interested to see if these neoadjuvant patients who are receiving chemoimmunotherapy will receive the CDK4/6 inhibitor in the adjuvant setting. So that comes to my question: what is the role of adjuvant CDK4/6 inhibitor in these hormone-positive, HER2-negative I-SPY patients treated with neoadjuvant chemoimmunotherapy? How we went about addressing this question is we did a retrospective study. We looked at 54 high-risk hormone-positive, HER2-negative I-SPY patients treated with chemoimmunotherapy, and we looked at their clinical-pathologic features, treatment response, and then event-free survival. A few cohort features is that the median breast cancer diagnosis age was 45.5 years, majority were pre or perimenopausal, and 14 were postmenopausal. The breast cancer types that were shown in this cohort, majority, 42 had invasive ductal carcinoma, 3 had invasive lobular carcinoma, and 9 had mixed histology. Of these 54 patients, we saw that 19 patients received CDK4/6 inhibitors in the adjuvant setting. So the types of CDK4/6 inhibitors they're receiving 15 received abemaciclib, 3 received ribociclib, and 1 received palbociclib. That makes sense since abemaciclib was approved earlier than ribociclib. And among this cohort of 19 patients, what we saw is that 18 were node positive at diagnosis, 17 were imprint negative, and 18 had a residual cancer burden, or RCB, 2 or 3 pathologic response. And we wanted to compare patients with the same characteristics to patients who didn't receive CDK4/6 inhibitors who also had a similar risk. So what we did is, of our total cohort of 54 patients, we had the 19 patients that received CDK4/6 inhibitor. And then we identified 16 patients who had similar risk to these 19 patients that received CDK4/6 inhibitor, but they didn't receive adjuvant CDK4/6 inhibitor. So these 16 patients who didn't receive adjuvant CDK4/6 inhibitor, similar to the cohort who did, were all node positive or high risk node negative, 15 were imprint negative, and then all similar to the group that did receive CDK4/6 inhibitor were RCB2 or RCB3. And what we did is we compared the difference in recurrence between these two groups of the real world outcomes. So on this bar graph on the x-axis, we have the group that received CDK4/6 inhibitor and then the group that didn't. On the y-axis is the number of patients, and in blue is the number of patients that had a recurrence. And what we counted as a recurrence was any local, regional, metastatic, new lesion, or if there was patient death. And the specific numbers is 19 patients who did receive adjuvant CDK4/6 inhibitor, there was 5 patient recurrences. And in the comparable subset, there was 3 patient recurrences. And these early findings of real-world outcomes for this patient group is that there is similar recurrence rates between the two groups. What we saw is that when we compared these two groups, patients who received CDK4/6 inhibitor had a comparable recurrence risk to patients with similar risk who did not take it. And although this is very early stages of looking into the use of CDK4/6 inhibitors for patients who receive neoadjuvant chemoimmunotherapy, it kind of brings into question, is taking CDK4/6 inhibitors worth it for these patients? Because the standard regimen is 2 years and it can involve a lot of toxicities, need for dose reductions. And so we do need larger data sets and longer term follow-up to really determine, is adjuvant CDK4/6 inhibitors optimal for these patients, or do we need to find better therapies? Now, I just want to thank first the patient who inspired the project for me and Dr. Bhattacharma. Can't include her name due to HIPAA purposes, but I do also really want to thank Dr. Homali Bhattacharma for helping me think of this idea and supporting me through this project. Dr. Laura Esserman for being such an amazing mentor to me these past 2 years in the internship, Francesca as well, and the I-SPY CRC team and BCC interns for making the 2 years here great. Thank you. That more treatment isn't always lead to better outcomes.
Excellent. That's good. That's good. Okay, do you have any questions?
Fantastic presentation, Alyssa. I loved it. I'm just wondering, in the initial conversations you had with this patient and Dr. Bhattacharma, what were the factors that Dr. Bhattacharma was considering without having seen this data? I just wonder what that conversation looked like.
It was interesting because this patient, she actually had a pathologic complete response at surgery after chemoimmunotherapy. So that's why it was hard for, Dr. Bhattacharma presented these options, but she's like, we don't know if the use of CDK4/6 inhibitors is really going to benefit you. And there are these symptoms involved. She ended up not giving the patient CDK4/6 inhibitor because that's what the patient wanted. But it was just interesting because this question, she didn't have data one way or the other.
Alyssa, great work.
Thank you.
I just have a question about you sort of matched paired the analysis. Is there a way to, and I think imprint is a binary kind of classification. Could you instead look at a continuous risk score and use I guess my question was, could you use a risk score like Oncotype or something else that's continuous, and then use that as a cutoff for a different kind of design to compare patients a little bit more granularly, like there's a regression discontinuity type of analysis or anything like that?
Yeah, I think that's definitely possible. I want to say like this project, we're still really looking into like the characteristics of these patients, and it was kind of like an exploratory chart review. So like first we took their characteristics that we knew, like node positive, imprint, and then compare that to recurrences. But currently we're still looking into more details, and we could definitely look at more of a broader scale of like oncotype.
Hey, that's a great presentation. I'm
Thank you.
just curious about your other your subset, right? What's the standard of care? Obviously, did you actually mention that for these patients that you're comparing it to?
I didn't mention it, but they generally just received endocrine therapy with OFS if they were still premenopausal.
5 years of endocrine therapy.
Well, the standards though have changed, right? So now everyone's getting, if you're node positive or if you were node positive to start, you would get that. If you had just had surgery first, which many people do, you would definitely get a CDK4/6 on the back end and not take into account that they had a PCR. So, and these drugs cost a lot, and they also have a copay, like $150,000 a year. And you might say, wow, you can't make a conclusion from 15 and 19 patients, although I want to know what happened to the other 20 patients, because that's 34, and there's what happened to the other 20 patients.
The other patients, they had a PCR, so
that didn't count. Okay. So, but I think it's great that people are starting to take that into account. And I have to say at ASCO this year, one of the most upsetting things was to see these giant trials, $1 billion for these trials. Okay, the difference between the Kaplan-Mekkers are significant only because they had thousands of patients, this much difference. Now, my first thought would be, well, maybe they're mixing in the people who don't need it with the people who do, so you can't see the signal. This makes me think probably not. And so, I think it's an amazing drug in the metastatic setting. It increases your lifespan like a year. But it's hard for me. I think this is really critical data. I think you guys should publish it just because it's so provocative. And it really does say that more isn't better, but maybe
there's better therapies out there.
Better. We should take a risk and do something better. And you're going to hear like more about some of that later, and some of the work in the organoids and trying to come up with something better. Well, everyone wants to give it, and it makes us feel better as clinicians, but nothing motivates you to change like taking a good cold hard look at the data and seeing how well you're doing. Thank you so much.
Thank you.
Annabelle, you're next.
Francesca, I'm going to delete the timer if that's okay. It's sort of just covering things for me. Hopefully I don't turn off the Zoom call. Okay, amazing. Okay. Yes. Hi, everyone. My name is Annabelle Duflock, and today I'm going to be presenting about a drug called Elagolix, which is a potential alternative to GnRH agonist ovarian function suppression in premenopausal breast cancer. The most important thing I've learned this year is that just because something is the best treatment option right now does not mean there isn't a better treatment option out there, and we just have to find it. Yesterday I was 36, and today I'm 85. This is a quote from a patient of Dr. Esserman's. Laura actually told this quote to me back in the fall, September or October, when we were first discussing this arm on the EOP trial that I'm going to be presenting data from. And she said that this patient told her that this is the reality of being a young woman with breast cancer for whom one of the main treatment options is shutting off your ovaries. So to back up a little bit, ovarian function suppression, or OFS, as I'll refer to it often in this presentation, is the standard of care for premenopausal women with clinically high-risk hormone receptor positive breast cancer. It's been the standard of care for a little over 10 years now, when the SOFT and TEXT trials showed that the addition of ovarian function suppression, or OFS, to the standard anti-estrogen therapy improved outcomes and improved rates of disease-free survival. Typically, this OFS is achieved via the use of GnRH agonists. So to give a little bit of a biology background, the hypothalamus releases something called GnRH, or gonadotropin-releasing hormone. GnRH then acts on the pituitary gland to stimulate the release of follicle-stimulating hormone and luteinizing hormone, or FSH and LH. FSH and LH then stimulate the ovaries to produce estradiol. And for women whose breast cancer is driven by estrogen, this increased estradiol and just the presence of this estrogen can feed their cancer and have it grow faster. So it is really important that we decrease this whenever possible. Also notable is that GnRH agonists block GnRH from acting on the pituitary gland, though they do cause an initial flare-up when they overstimulate the pituitary gland initially, but they do ultimately suppress ovarian function really effectively. However, the side effects of OFS can be hugely burdensome for patients. The rates of discontinuation of OFS in the SOFT and TEXT trials were about 19%. So about 1 in 5 women couldn't even tolerate this really important piece of their treatment. Some of these side effects include depression, cognitive decline, osteoporosis, weight gain, insomnia, anxiety, fatigue, musculoskeletal symptoms, cardiovascular toxicity, sexual dysfunction, hot flashes, and more. So the question that many of the I-SPY investigators began to ask was, with the standard of care OFS options being such a challenge, are there any other equally effective and more tolerable forms of ovarian function suppression in women with hormone receptor positive, HER2 negative breast cancer? So this is where we get into a drug called Elagolix. Elagolix is a GnRH antagonist. So you can see in this diagram here, the orange section in the middle is showing the mechanism of action of an agonist drug, which, like I mentioned, is the current standard of care for how we achieve OFS in these women. These GnRH agonists have a similar structure to natural GnRH. So like I mentioned earlier, they can cause an initial flare in estradiol levels in patients. However, GnRH antagonists, of which Elagolix is one, block the GnRH receptor, so we typically see immediate suppression. This different mechanism of action, specifically avoiding the initial flare, was one of the things that drew investigators to be interested in trying Elagolix as a new OFS option. So before this trial, Elagolix had been FDA approved for endometriosis-associated moderate to severe pain at a dose of either 150 milligrams once daily or 200 milligrams twice daily. And in breast cancer, there have been published case studies showing that Elagolix could be a backup option for when GnRH agonist suppression failed in patients. The tools that we used for evaluating Elagolix in the I-SPY EOP trial, so the endocrine optimization pilot that Alyssa and I discussed previously, were 3 questions. First, we wanted to see, did estrogen levels drop as measured by estradiol, specifically a central hormone serum testing assay done at the Mayo Clinic? Then we wanted to see, did we have the right impact on the tumor as measured by Ki-67 levels? And then finally, we wanted to see, did patients feel better as measured by our electronic patient-reported outcomes as well as site-reported adverse events? So from August 2025 to April 2026, 26 patients were randomized, 13 patients to each arm. We had 13 patients randomized to Z-endoxifen, which is standard anti-estrogen therapy plus GnRH agonist. And then we had 13 patients randomized to Z-endoxifen plus Elagolix at a novel dose of 150 milligrams twice daily. So this is the timeline that we used for taking samples for central hormone serum testing. All the green dots here show time points where we took samples from patients' blood samples. So all the patients on both arms notably started their OFS 14 days before initiating their endoxifen treatment, and we took blood for their central hormone serum testing to get estradiol results before they initiated any OFS, and then at various time points throughout their treatment. And then, sorry for the rogue purple circle, we had biopsy collection done for Ki-67 analyses, and we had biopsies done prior to any treatment and then also at week 3 of treatment. And this is important to get these biopsies at week 3 of treatment because Ki-67 is actually a validated biomarker of response to neoadjuvant endocrine therapy. So a decrease at the 3-week time point is actually associated with higher sensitivity to treatment, lower recurrence risk, and better outcomes overall. So it's really important that we gather data from these biopsy specimens to assess if we're having the right impact on the tumor in both arms of this trial. And then finally, we assessed for tolerability via the FACT-GP5 and site-reported AEs. This is what the FACT-GP5 question looks like for patients when they fill out their weekly and monthly surveys. They're given the statement, I am bothered by the side effects of treatment, and then asked to rank that from 0 to 4, 0 being not at all, and 4 being very much. And these patients were given these surveys weekly, starting at their first endoxifen treatment, and then for the first month, and then monthly from there. Okay, so to start off with the results from our central hormone serum testing, these are the E2 and E1 results, or estradiol and estrone. Overall, we saw similar estradiol suppression in both of these arms. These graphs, like I said, are showing both E2 and E1. The endoxifen plus Elagolix arms are shown in orange, and the endoxifen plus GnRH agonist arms are shown in dark blue. And you can see that from baseline before the initiation of any OFS to around 6 weeks of the endoxifen treatment, or 8 weeks from the start of OFS, we'd achieved full suppression in both of the arms. Additionally, Ki-67 was seen to decrease at the 3-week time point in both of these arms similarly. So we took samples, like I said, from baseline before any treatment to 3 weeks on Z-endoxifen, and we saw similar Ki-67 decreases, which is prognostically good. And finally, in this graph of FACT-GP5 data, I want to point out that higher responses to the question or the statement, I am bothered by the side effects of treatment, indicate poor tolerability. So when you see higher scores here, this indicates that patients were tolerating treatment worse. And here the GnRH agonist arm is shown in orange. And you can see after 4 weeks of treatment, the GnRH agonist patients had higher reported scores to the FACT-GP5 question, indicating that they had poorer tolerability than the patients on Elagolix. So the key takeaways here are that both Elagolix and GnRH agonists suppress ovarian function as measured by estradiol. Additionally, both arms saw Ki-67 decrease after 3 weeks on neoadjuvant endocrine therapy, which is prognostically a good sign. Additionally, patients on Elagolix reported a higher quality of life. These pilot data support further evaluation of Elagolix as an OFS strategy for women with premenopausal high-risk breast cancer, specifically those receiving neoadjuvant endocrine therapy. Future directions for this project would be to continue gathering data as the patients in these cohorts finish their neoadjuvant endocrine therapy. It would be great to see Ki-67 numbers from their surgical specimens, as well as their FTV scores or functional tumor volume, response over 6 months, EPROs, which are electronic patient-reported outcomes, more results from central hormone serum testing, and of course, the residual cancer burden scores or RCB scores from these patients at the time of surgery. It would also be great to enroll more patients for more statistically sound analyses. A lot of these analyses are hindered by low N values. And then, of course, it would be great to see long-term outcome data for these patients on these in this cohort, as well as discontinuation data. And I would, of course, like to thank all of my amazing mentors, both in this project and throughout the year. I've had a ton of support as an I-SPY clinical research coordinator and in various projects that I've done at the BCC. And I've had an amazing year, and I'm glad that I have one more. Thanks.
Questions from the audience? Okay, Jackie.
Great job, Annabelle. So as you were going over the mechanism of action and that this is for mostly premenopausal women, I was just curious if you guys plan on looking at like bone mineral density and how that might be affected in the premenopausal patient group, and if so, maybe share the thoughts.
Yeah, as in between the two arms, the DEXA scans, I think that'd be really important to look at because, like, as I'm sure many people know, the anti-estrogen therapy can have really negative effects on bone health. So I think it would be really interesting to see if maybe Elagolix doesn't negatively impact bone health as much as other therapies. I don't have any specific plans to lead that charge, but I think it would be really interesting to talk to the investigators about.
You need a really large cohort for that too.
Yeah.
But, I mean, and the thing is, it's very interesting because if you take it for 3 years and then you stop, but the people who have persistent, that's with a softened text trial showed that the people who actually achieved menopause did much better. Of course, those are going to be the people who have long-term bone health issues. Of course, that brings up the whole new issue is that now there's this demand, like when can we take hormone replacement therapy? So that's like a whole new thing. Perfect segue to Erin McCurry, who's going to lead the charge on trying to answer those questions.
I don't know about that, but
this is maybe more of just a thought than a question, but if you do continue this work, I would say two other things I was curious if you had considered is both convenience for the patient and cost, because Elagolix is oral and the other drugs are injections. And I will say that just and it's given in the infusion clinic, which I imagine comes with a lot more cost. So I think those are two other arguments, especially if this is ever brought into the adjuvant setting, that would be a huge change for patients and for cost.
I think that's a really important point.
It's to me, it's such a great thing. The sad thing is, guess who's the least interested in moving this forward? AbbVie, the people who make Elagolix. Isn't that incredible? They said, no, we're going to stick with our itty bitty approval for endometriosis, and we're not going to lean into women's health.
This would be a huge change for the quality of life.
Yeah. It's just super frustrating. Okay, we're going to put that on your list of things to work on. I saw someone else who has a question. Okay. Fantastic job.
Thank
Wonderful.
you.
And that's going in as an abstract to San Antonio. Very exciting. Well, we're going to have to work on bringing AbbVie to their knees. Okay. So, all right. So our next up is Sarah Choi, who's going to actually reveal some we're going to continuing on in the frame of people doing really cool things that then the companies decide not to invest in. Anyway, we're really excited to hear about the next topic, which is rapid readout of biomarkers to improve access to diagnostic tests everywhere. Sarah.
Hi everyone, my name is Sarah and I'm a second-year intern, and I'll be presenting on my project evaluating the Xpert STRAT4 assay to rapidly generate breast cancer biomarkers. So something that I learned during my time in the internship and working in the I-SPY trial is just how much science continues to expand what is possible for patients and improve the standard of care, as we've heard from Annabelle's presentation. But at the same time, I've also realized how equally important it is to make sure that this kind of high quality care is accessible to all patients, no matter their background and circumstances. So that really led me to my project, which is investigating an automated mRNA assay called STRAT4 to enable faster and more accessible biomarker testing. In breast cancer, we have three main biomarkers. So that includes the estrogen receptor ER, progesterone receptor PR, and the HER2 protein, which are used in the surrogate subtyping of invasive breast cancer. And they play a really important role in classifying clinical subtypes and guiding treatment decisions. These biomarkers are currently routinely assessed by fixing the tumor tissue, embedding it in paraffin, and slicing it into thin sections, which are then stained using immunohistochemistry or IHC. Additional in situ hybridization testing is also performed when the HER2 status comes out as equivocal. So working in the I-SPY trial has shown me not only how important it is to how important these results are for the patient, but also how it can be one of the last pending results for screening. At the same time, though, in other locations, I was also struck that only 69% of patients in Tanzania received any form of receptor testing. So this ultimately means that we do need faster, more accessible ways of assessing biomarkers, which led us to exploring alternatives to IHC. Although IHC and in situ hybridization are standardized methods, they are quite labor and time intensive and can be influenced by assay reagents and variability in pathologist interpretation. Gene expression analysis, therefore, offers an alternative approach to rapid biomarker assessment and may provide additional insights into the continuum of expression levels that could be prognostic or predictive of treatment response and clinical outcomes. So in this project, we evaluated the STRAT4 assay, which quantifies mRNA expression levels of ESR1, PGR, ERBB2, and MKI67. And this is all normalized to a reference gene. The assay requires less than 10 minutes of hands-on time and has a turnaround time of only 2 hours. So we think that assessing the performance of STRAT4 may help determine its utility as an alternative to traditional IHC, particularly in resource-limited settings. We evaluated this test in collaboration with the I-SPY lab and Cepheid, and we ran this on pre-treatment biopsy samples from I-SPY 2. Our primary objective was to evaluate the performance of the STRAT4 assay for ER, PR, and HER2 using I-SPY pre-treatment biopsy core samples at UCSF. Our study included 218 patients with breast cancer receiving neoadjuvant chemotherapy or endocrine therapy. We analyzed concordance between the STRAT4 test and local IHC results for these biomarkers from this pre-treatment biopsy using overall percent agreement, positive percent agreement, and negative percent agreement. And then we looked at the associations between STRAT4 gene expression levels and PCR or pathologic complete response, which we reported as odds ratios. So here are the results for ER and PR concordance. The overall percent agreement was high at 89% for ER and 88% for PR. The positive and negative percent agreement for ER was 92% and 85% respectively, and for PR it was 94 and 83%. Below this table are jitter plots showing the distribution of concordant and discordant cases. So the top right and bottom left correspond to concordant cases, while the top left and bottom right include the discordant cases. So among discordant ER cases, 13 were STRAT4 positive and 11 were STRAT4 negative. And for PR discordant cases, this included 19 STRAT4 positive and 6 STRAT4 negative cases. The overall percent agreement for HER2 was 85%, with a positive percent agreement of 98 and a negative percent agreement of 79. Among the discordant cases, there were 28 STRAT4 positive and 1 STRAT4 negative case. Additionally, we actually met with Cepheid representatives this morning, and they also suggested that they're exploring an alternative cutoff. And so I actually repeated this analysis with the alternative cutoff value of negative 0.25, and I did find that the concordance significantly increased. So this is something that we're more interested in. Okay, so the primary objective was able to show that the STRAT4 test was able to reliably predict biomarkers for ER, PR, and HER2. And in our secondary analysis, we were interested in looking at associations between gene expression levels from STRAT4 and how that correlated with pathologic complete response, or PCR. We analyzed gene expression levels from STRAT4 and showed that PCR following neoadjuvant therapy was positively associated with pretreatment MKI67 with an odds ratio of 1.78. We also found that PCR was negatively associated with pretreatment ESR1 or ER with an odds ratio of 0.75. PCR was also negatively associated with the progesterone receptor with an odds ratio of 0.68. And finally, we observed no significant association between PCR and HER2 expression. So our findings demonstrated that there is high concordance between STRAT4 and standard IHC testing, supporting its reliability for breast cancer biomarker assessment. Discordant cases were also more frequently STRAT4 positive, we noticed, which potentially reflects differences between mRNA and protein-based measurement methods. We also observed that there were higher PCR rates with higher Ki67 and lower ER and PR expression. This shows how like this continuum of gene expression data from STRAT4 may provide insight into how baseline tumor biology may help predict treatment response. So in conclusion, our data suggests promising clinical utility of STRAT4 as an automated approach for biomarker testing, which may reduce reliance on traditional histology workflows. We're excited about this since these advantages may be particularly valuable in low resource settings where pathology infrastructure is limited. I'd like to thank all of our project collaborators who have helped with this project, as well as everyone in the BCC internship who have given me so much support and guidance throughout the past 2 years.
Were they excited about the results?
Yeah, they were. Yeah, they
changed their mind about.
So there were multiple people from Cepheid on the call, and I think they were excited to hear about it, and they are developing the research version of it. So I hope that they're able to continue this work.
Did they suggest maybe a different threshold for the ER and PR as well, or?
We didn't talk about that. We only talked about HER2 mainly because that was the lowest concordance of the 3, but that's something that we're also interested in.
They really improved it. I mean, that might be better than FISH and all kinds of things. Actually, yeah, I think, and I was trying, I didn't quite get a chance, but when it was discordant, so STRAT4 found more.
STRAT4 was more positive, yeah.
Could actually, we should show it to Fraser and see if he wants to think about trying to compare it to his set index, the sensitivity to therapy, because it ought to be more concordant with that. It was kind of interesting. Yeah. Although he won't like it because it'll compete with his test. Anyway, yes, Jeff.
Yeah, I forgot to introduce myself last time. My name is Jeff Belcora, and Sarah, great work.
Thanks for the mic. So this takes me back to the very first project I ever worked on with Laura Esserman 35 years ago. Laura, do you remember our CART analyses? Yes. So we had a different outcome we were trying to predict.
I want you to know I use that all the time.
Yeah.
Our CART it's the version of that is.
Yeah. So my comments may be a little dated, but a couple of thoughts on this. One is when somebody presents a better cutoff, like your colleagues did, you do have to go back and validate that on a training set and then a validation set, because it's overfitted when you just go back and find a cutoff that just works better for the data that you collected. So that's one.
But they suggested you hadn't, not on this. They gave her another cutoff that she had never tested.
Yeah, it's subject to bias. That's my thought on that. But then the other thing is that I didn't catch all the mechanisms of how the test works, but often when you're trying to improve the positive and negative predictive value of a cutoff score or something, if you can go back and just have patients, if it's that much cheaper and more convenient, if you can just have them do sequential tests, repeat the test, and then you do the kind of fancy statistical analysis on it, you will substantially improve usually the ROC curve.
It's a cycle time. You could just probably run it 3 times, right?
Yeah, this was
it in triplicate by any chance?
So this was done by I-SPY Labs. So I'm not completely sure how many replicates they did. But I think that would be like the best practice to do it multiple times to test reliability.
That's actually a really good idea. The FDA, of course, will want that anyway.
Yeah. But just for decision-making purposes for an individual patient. Anyway, I don't understand the mechanisms of exactly the test, but
so the IHC is protein. They're looking for protein on the cell surface. So you're staining an antibody on the cell surface. This is actually looking at the expression, the genes that result in ER, PR, and HER2 expression. So it's really interesting how well it correlates.
Cool.
Yeah. Yeah, thank you.
Any other questions? Yes, one more. Belinda in the back. Yeah.
In a low resource area, I'm unclear. I don't know. If you're in a low resource area, is this
tests going to help you get the treatment? Are the treatments available?
It's a critical start if you don't have this data. I mean, what we really want to do is also look at imprint. So Nashi Kivuyo, who is part of this, is actually in Tanzania. And so we're working on trying to have something I-SPY like in Tanzania. So of course, when you start anything or have any new test, you don't have the resources, but how you start is by showing that your population has a particular characteristic. Just as an example, Fumi Olopade was the first to introduce IHC testing in Nigeria. Everyone who had breast cancer there got tamoxifen. All these young women with these terrible cancers, and 80% of them were hormone negative. So that tamoxifen was not helping them. And yes, that changed care.
Well, I'll just add on that note, in a middle resource setting, like where I just came from in rural the United States, my biopsy results had to be sent. I had to come in on a certain day. My biopsy results had to be flown out before the weather came in to another part of Colorado. So I was excited to see that when you introduced it.
Yeah, absolutely. There are places in this country that are very low resource setting and cannot get the standard of care when when it is available. It's so, right? So unfair.
Yeah.
Great work.
Thanks
for presenting. Okay. Next up, we're going to move from invasive cancer to DCIS, to the precancerous setting. And we're going to hear from Thomas Lee a little bit about the RECAST trial and the tools that we're developing to try and help figure out how to optimize therapy. All right, Thomas.
Is there a clicker or is it you click that up?
Just keep going. Sure.
Great. Well, hi everyone. I'm here to present optimizing an imaging-based risk algorithm to personalize treatment for women diagnosed with ductal carcinoma in situ. To start off from my lesson from the year, when confronted with numerous problems simultaneously, success depends on being decisive and efficient in execution, often with less time than ideal. But I think this is also pertinent to the inspiration for this project, in part because we were reviewing how to revise an algorithm for patients who were enrolled in a trial and who were relying on this decision-making tool to help inform treatment planning. And this goes back to Sarah's presentation about how we need knowledge in a timely and informative manner for patients to help make decisions at all points of treatment. And so this is a study or project about for patients who are diagnosed with ductal carcinoma in situ. It's a biologically heterogeneous condition in which there are malignant cells confined to the breast duct. It's clinically defined as a stage 0 breast cancer. The key fact about this precursor is that there's variable risk of progression to breast cancer. Somewhere between 20 to 50% of lesions, DCIS may never progress to invasive cancer in a woman's lifetime. In spite of that, the standard of care treatment for DCIS is surgery, often followed by radiation or endocrine therapy to reduce future risk of recurrence. And this is nearly identical to how we treat stage 1 invasive breast cancer, even though DCIS is a stage 0 breast cancer. And so this raises the question of if some cases of DCIS are overtreated through standard treatment, if they may never progress to invasive breast cancer. Of the 250,000 cases of breast cancer diagnosed annually in the United States, about 20% of those are diagnosed as DCIS. And so that could be up to tens of thousands of women who are overtreated through the standard approach. The challenge, though, is how can we identify and personalize treatment based on individual risk of DCIS progression to invasive breast cancer? And so there have been a lot of clinical trials outside of UCSF that have tried to investigate if we can do something other than surgery, namely an active surveillance approach in which we watch a lesion using different imaging modalities and observe if it progresses over time. And sometimes this is paired with hormone targeting endocrine therapy. In the context of UCSF, there were Dr. Esserman and colleagues previously treated patients who declined surgery and opted for an active surveillance approach with a standard of care endocrine therapy. This is like tamoxifen or an aromatase inhibitor. And these were patients who had obtained MRIs before starting endocrine therapy and a few MRIs following the endocrine therapy. And we have long-term follow-up data to identify which of these patients DCIS either remained as DCIS or progressed to invasive cancer. And so when we look back, when Dr. Esserman and radiologists looked retrospectively at all of these MRIs in this cohort of 63 patients, they identified two features on these MRIs that helped inform an imaging-based risk algorithm, those being the background parenchymal enhancement as well as the lesion distinctness. And so the background parenchymal enhancement describes the enhancement of normal breast tissue on a contrast MRI. There's a standardized classification increasing from minimal all the way to marked. What this basically, I'll show this in the next slide as well, but patients can have a spectrum between low to high BPE as evidenced by like the cloudy, opaque background that is present on these breast MRIs. The other feature that we tried that was used in the previous in the algorithm derived from those 63 patients was a question of lesion distinctness. Is there a visible lesion that stands out above the background, the normal background of breast tissue in patients diagnosed with DCIS? It is very possible that there are patients for whom there's no visible lesion on DCIS, even though there's a biopsy-proven DCIS. Most patients with DCIS present with a non-mass-like enhancement, or NME, which is, it can appear as a diffuse, opaque pattern on an MRI, demonstrating scattered areas of DCIS lesions in a woman's breast. And that could reflect DCIS that'd be more amenable to endocrine therapy as opposed to surgical intervention. DCIS can also present as a mass, which is more correlated with a focal local risk of developing invasive cancer, which may be more amenable to surgery. But of course, we're still trying to prospectively understand these lesion types in the RECAST trial. And so in the 63 patient cohort, they developed this imaging-based algorithm that tried to risk stratify patients for their risk of developing invasive breast cancer in the next 5 years. We had a low, intermediate, and high risk categorization. Low meaning recommended active surveillance and endocrine therapy. Intermediate decision risk corresponding to shared decision making between active surveillance or surgery, and a high risk recommending surgery. And we implemented this algorithm in the RECAST trial. RECAST is a phase 2 trial offering patients diagnosed with hormone receptor positive DCIS endocrine therapy to see if their DCIS can be effectively treated in that approach. Analogous to how Annabelle presented about the I-SPY EOP trial, in which endocrine therapy is offered to try to de-escalate patients from chemotherapy. This goal is to see if we can de-escalate some patients from a surgical intervention with these endocrine targeting agents. And so the risk algorithm is implemented in that at 3 and 6 months following endocrine therapy. We look at their MRI and we see what features correspond to their relative risk level. When we implemented this algorithm in the RECAST trial, we did an interim review of our interim and high risk cases. We have over 100 patients currently enrolled in the trial. And when we did when we reviewed some of our intermediate and high risk cases, we found that we wanted to reinvestigate some of the imaging terms defined in the previous algorithm. The algorithm was derived by 2 radiologists at one site, UCSF, but is now being distilled across 30 sites nationally with many more radiologists and the potential for inter-reader variability. And so when we decided to reinvestigate this original algorithm, we went back to our retrospective cohort data. We actually compiled a larger cohort than the original set that the algorithm was validated upon. And we used recursive partitioning with more replicable, standardly reported imaging terms, looking at how changes in background parenchymal enhancement and lesion size can inform risk of progression. And so with that, we refined an algorithm with more reproducible terms to better classify low, intermediate, and high-risk patients based on long-term invasive breast cancer recurrence. So this is our decision tree, but the high-level overview is that we use pre and post treatment imaging features to assess who is at low, intermediate, and high risk. And we can use this algorithm for patients across the menopausal spectrum, patients who have a visible lesion or don't have a visible lesion at baseline, to really inform treatment decision making in the RECAST trial. And our revised algorithm reflects that we were able to stratify women into low, intermediate, and high risk with 7, 25, and 52% risk of predicted invasive breast cancer recurrence within 5 years. And so in our algorithm, if you had a lesion that persisted or increased after endocrine therapy, but the actual background decreased, that suggests an intermediate to high risk as it relates to invasive breast cancer recurrence. This MRI shows a lesion that is appearing above background after at baseline, it was kind of hidden with the background. And so this accounted for roughly 16 and 27% of our retrospective cohort of 99 cases. In comparison, if we saw that the lesion reduced as well as the background parenchymal enhancement, that suggested a lower risk in which you could safely continue active surveillance and endocrine therapy. And this accounted for a majority of our patients in our retrospective cohort. So just quickly showing another imaging example, pre and post treatment, we can see that for some patients, their lesions can decrease or resolve completely over MRI. And that suggests that these are patients that could have been spared surgery for their DCIS. And so this suggests, but this of course needs to be validated in future prospective studies, but if most patients could be comparably reducing their risk of invasive breast cancer recurrence with endocrine targeting therapy as opposed to surgery. And so our ongoing milestones are to implement this algorithm in the RECAST trial to ensure quality control and improve training. We also want to look at our risk distribution of our first 150 patients on the RECAST trial to see if we have similar distributions to what we saw in our retrospective cohort. And so we've developed this imaging-based algorithm that aims to identify people for whom the risk of invasive cancer can be comparably reduced with endocrine therapy versus surgical excision. And this is also parlaying to what Josh and Chaelee will talk about, but all of this is trying to envision a new paradigm for personalized treatment for DCIS. Because even though surgery is one treatment option, it is not the only option. And we should be giving patients knowledge and information to make those decisions. And with that, just want to say a huge thank you to all of my mentors here at the UCSF BCC, our co-interns, and then also my UChicago mentors who got me to the BCC. Thank you.
Great job, Thomas. Unfortunately, you won't be going far, so, more closely proximate to the vortex. Sandy.
You probably know what I'm going to say.
I was thinking about this last night.
It's a piece of data that we need to really improve your study, which is invasive breast cancer is not the right endpoint. We need to know what kind of invasive breast cancer. Is it a consequential cancer or is it an indolent cancer? And we really need to get that data on top of RECAST to give patients real answers. Right now, 7% risk, that's very high. And people, well, it's
not compared to surgery, radiation, and
granted, but it's still higher than I would expect. But that's because it includes everything we would call invasive cancer. Probably even includes microinvasion, but I don't know. We'll have to look at that. So anyway, I think that's the next step, is figure out what's your risk of a real cancer versus an indolent cancer.
I suppose we could, we actually have all the cases. Oh, that's actually pretty low hanging fruit. Want to do that, or are you going to give it to your co-interns and work on it with them? That's pretty low hanging fruit, actually.
Excited to do that with my co-interns.
Yeah, fascinating work. Thanks, Thomas. The thought I have for all the interns who've been participating in the patient support corps is you've probably seen risk discussions between doctors and patients. And it's just important to remember that, from a shared decision-making point of view, and Laura refers to this as personalizing care to the patient preference, that we all have an internal thermometer where, how shared decision making is ultimately about how do you feel about three things: the risk, the timing, and the likelihood of outcomes. And there can be such patient variability that a patient might see the 7% risk, and that might loom large in their life. And there could be, you want to inform the reasons for why that might loom large. And if they're based on misconceptions, you might be able to reduce the loomingness of that, 7%. Whereas for some other patients, 25% might not loom large. And I know I've seen Laura and other physicians, try to have that conversation about informing possible misconceptions, but then ultimately yielding to the patient preference. Because, while Laura might say, oh, I'm concerned about you being overtreated, in the end of the day, the patient might just have that internal thermometer that is a differently calibrated thermometer than Laura's or than mine or than anybody else. Yeah. So I think it's super important work to keep driving this issue of active surveillance and overtreatment. And it's also important to just keep in mind that people's thresholds, as Laura says, will really vary. And that's part of just being human and having different human life experiences.
For sure, to both points. I think Sandy's point reminded me, I got a question at Atlanta when I presented. I think one of the American Cancer Society professors also said 7% still seems quite high to me. So certainly
put that it was important that we put that in perspective. This is compared to the NSABP trials and so on, right?
Right.
And that's like, it's not zero. Nobody's risk is zero. That's actually really, really important. I keep forgetting to do that, but anyway.
Right, not the spine area of 0 to 100.
Right. It's like, I think the risk in the NSABP trials is 12%.
The risk of a lethal breast cancer might actually be pretty close to 0.
I don't know that, but we'll find out.
And to Jeff's point, with the recast trial, we're capturing data about what providers recommend in light of this risk assessment, also what patients prefer, and we'll hopefully look at the concordance or disconcordance. So yeah, thank you.
But I wanted to wait. When I expect time, we have one more question. But I wanted to tell you, who, when in the active surveillance study of the people who decided not to have the surgery, the vast majority were from what profession? No, definitely not. Those are risk-averse people who are really analytic and really thoughtful. Engineers. They're all engineers or software CEOs or whatever. It's just so funny. They're like, I've read all the literature. This makes no sense. Why are you doing this? I said, well, okay. If you don't want to do it, I'm happy to follow you carefully. But they could recognize, because they would go back and they said, I've read all these papers. What is this? It's very interesting. Yes.
Amazing presentation, Thomas. I loved it. And you've worked so hard on this all year. So great to see it. I'm just wondering if there was one imaging feature that was most surprising to you as you worked with Laura and Dr. Greenwood to craft this ROR. Was there anything that you didn't expect to be as impactful in assessing risk through imaging?
Sure. I think going into this, I had thought that some of the measures of focality, like segmental distributions, were factored into the original tree. But in fact, as of now, we're not doing that. But of course, when we accrue more data with recast, and also even in our retrospective cohorts, I'm curious to see how those might inform certain lesions for upgrading or de-escalating.
It's a balance too, because the radiologists, again, it's one thing to do it. If I were doing it, I would have a different frame of how I look at it. I've been doing it for 15 years, right? But they're not the BIRAD's way of classifying these cases. And if you want to disseminate it, you can't make up your own categories that have to fit into the way that other people see it. That's actually how we got in trouble with the algorithm that we started the trial with, because the way radiologists interpret this, we had to put it into radiology speak language, right? So that we could get it to replicate with fidelity. You have to give up, so you lose some important information, but but that's the trick. I mean, that's the trick of having to, disseminate something. Great. Okay, fantastic. Aren't these talks amazing? Amy, I don't know if you've joined us online, but in case you have. All right. have this? Yeah. Okay. Speaking of which, I'm busy composing an email to the IRB right this minute, which I probably won't send. But anyway, okay. We're going to hear from Chaelee Park about the immunotherapy injection study, another really important window of opportunity, neoadjuvant approach to figuring out how to manage the higher risk lesions. These we know are on their way to higher risk cancers. Right, Sandy?
Hello, everybody. My name is Chaelee Park, and I'm so excited to be here with you all today. And one big thing I've learned this year is what patient-centered care looks like in research and also in patient care as well. And I've seen that in so many different ways at the breast care center, but one aspect that really struck me is the way that advocates are always present at the breast care center events and also even help out with looking over consent forms and protocols as well. And I think that's really special in terms of centering patient perspectives and priorities. So that's something that I hope to bring with me throughout my career. So today I'll be presenting on the immunotherapy injection study for DCIS. And our goal with this study has been to investigate new therapies because new strategies for DCIS are needed. As Thomas mentioned before me, DCIS is non-life-threatening and may be overtreated with current standards of care, which are surgery with and without radiation and endocrine therapy. And DCIS is treated primarily in the same way as Thomas mentioned, despite the fact that not all DCIS has the same biology, meaning that not all DCIS carries the same risk. We have low-risk DCIS, which is 80 to 85% of cases, and this is the patient population included in the recast trial that Thomas presented on. And these patients could be suitable candidates for active surveillance. But we also have high-risk DCIS, which composes of 10 to 15% of DCIS cases that would not be appropriate for active surveillance, since a majority of subsequent invasive cancers and poor outcomes come from this high-risk group. And a study of a big DCIS cohort showed that those with less chance of progressing to subsequent invasive cancers from DCIS were those with more immune cells in and around their lesions. So that begs the question, can we unleash the immune system to get rid of this DCIS? Previously, we looked at injecting pembrolizumab alone at the breast care center. And so we had a cohort of patients that received a direct injection into the DCIS of pembrolizumab, which is a PD-1 inhibitor. And it aims to take the brake off of the immune cells so that they can activate against the DCIS. And what we saw is an increase of immune cells that came into the DCIS area, but it didn't get rid of the disease. So we knew we had to add something more to activate the immune system and hopefully get rid of the disease. And so we added local injections of mRNA-2752, which is a drug coding for OX40 ligand, IL-23, and IL-36 gamma, which are all immunomodulatory proteins. And 10 patients received both drugs together, pembrolizumab plus the mRNA drug, and 11 patients received the mRNA drug alone. And this is what the study timeline looked like. Patients had an MRI pre and post treatment, and this allowed us to track changes in tumor volume size. And patients also had tissue taken from their lesion through core biopsy before treatment or biopsy or surgical sample after treatment. And this allowed us to look at what the immune cells looked like in the DCIS lesion. Patients also had blood collected before and after therapy, and this allowed us to look at the systemic immune response. And the treatment consisted of between 2 and 4 injections administered 2 to 3 weeks apart. And also patients had blood collected at each injection time point as well. And so here are some examples of response based on MRI. On top is an example of a complete responder. You can see that DCIS lesion pointed at by the yellow arrow goes away over time, 4 weeks and 7 weeks. And below is an example of a partial responder. You can see that lesion gets smaller over time. So overall in this study, 8 out of 21 patients had either a complete response or a partial response. 6 patients came from the dual therapy arm, so they received both drugs. 2 came from the monotherapy arm, just the mRNA. And complete response is defined by regression of disease based on MRI and confirmed by biopsy. And partial responders are people who had over 30% decrease of tumor volume based on MRI. And the rest of the patients had either stable disease or progressive disease. So given these clinical responses, we wanted to answer 2 primary questions. Are there differences in the tumor immune microenvironment associated with response? And also, are there differences in circulating autoantibody levels associated with response? And when we looked at the tumor microenvironment made possible by the tissue samples from patients, we saw that in pre-treatment tissue samples, responders had a higher percentage of B cells in the dual therapy arm compared to non-responders. And we looked at other immune cell types other than B cells as well, but B cells were the only ones with the significant difference. And when comparing the tumor microenvironment pre and post injections over here, we saw that T cell infiltrates increased in both cohorts and B cells increased in the dual therapy arm. And a note here is that complete responders are not included in this analysis because they had that regression of the DCIS and therefore no DCIS tissue to analyze there. So in the previous slide, we saw that B cells were associated with response to therapy, so they might be an important piece in the puzzle here. And we wanted to see if there was more evidence of the importance of B cells. And we know that in the body, B cells produce antibodies. And autoantibodies are specific types of antibodies that react with self-antigens, which could possibly be tumor antigens. And so we looked in the plasma, which is the antibody-containing component in the blood, to look for autoantibody reactivities associated with response. And what we found when we looked at pretreatment blood is that among 25,000 autoantibodies screened, there were 176 response-associated autoantibody reactivities. And of these, 166 came from responders and 10 exhibited higher reactivity in non-responders. And this schematic over here shows the trend that we saw, tying what we saw 2 slides ago with the immune cells in the DCIS with what we see in the blood. So responders are on the left side. You can see the DCIS has more B cells, those blue cells in and around the lesion. And good response also correlated with more autoantibody reactivities. And on the right side is an example of a non-responder, which correlated with lower B cell percentages and also correlated with lower autoantibody reactivities in the blood. And when comparing pre and post-treatment blood samples, we saw 39 autoantibodies were increased in responders and none were increased in non-responders. So overall, the data suggests that B cells play an important role in mounting and organizing an immune response in the context of immunotherapy injections. And so the presented study is proof of principle that such locally injected therapies are safe, tolerable for all patients, and induce immune activation and clinically significant outcomes in a subset of patients. And findings support B cells and autoantibodies are important in mounting this anti-tumor response and could potentially be predictive biomarkers to response as well. So our future plan is to look at circulating cytokines and chemokines to look at that systemic immune response. And we're also excited to hopefully start more phase 1 studies on new immunotherapeutic agents. And I would like to extend a huge thank you to all my mentors on this project and everybody that I've been able to work with at the BCC, especially Laura, Mike, Sandy, Anna, and Francesca, Jeff, the other interns and patients. I'm really grateful for all of the professional and personal development that you've helped foster in me. So I'm really grateful. Thank you.
I'm particularly happy to see the Halloween costume photos featured so prominently in all of these trials. It is so the most important question I have for you is, should we now have, is this ready for the prime time? Can we use autoantibodies to screen for whether or not they should be given immunotherapy injections? Too soon. What do you think? You answer.
Oh, I was.
Forget what he said. What do you think?
I think.
If we can validate it, maybe that's what we should.
Yeah, maybe too soon.
Mike.
Yeah, I think it needs to be validated. I think there's a signal there, and I think it's interesting, but I think
there's a good signal there.
Yeah, and there's a good signal. I will mention that
especially.
We put in a CBCRP grant, did not get funded this year for doing it, so we got to convince people it's worth doing.
Well, did you have this data?
Yes.
You did?
Yes. But no, I think it's interesting.
So
and
annoying.
The other thing I'd point out is that, I mean, antibodies really are, a biomarker of what's going on in your body. So I think it's an interesting area we should be looking more into. And
it's not just about the T cells, right? It's about the B cells.
Yeah.
Mike and I did show that in 1986.
Yeah, I was going to say you definitely got to look at it, but you also got to remember to look at the T cells and probably the Tregs and what they're doing, because we have ways to modify all of the above, and we got to know on a per patient basis, how do we tweak their immune system for optimum care? It's personalized medicine, Laura.
Well, okay. Thomas, how are we going to incorporate what's his name? James Redding's T regulatory cells, circulating T regulatory cells. If we can link the that's what the next grant should be. Circulating Tregs, B cells, autoantibodies, and something else. All in our part. Cart or whatever we use. Any other ideas?
I'm excited I think they're working on, I think it's some PI3C KC kinase, some peripheral Treg intrinsic mechanisms. So that'll be really exciting to see what pathways could synergize and maybe breast and lung lesions, perhaps.
Stay tuned. Rachel.
Have you considered the role of the microbiome in improving immune system?
Yeah, no, that's a great question. So previously, when these patients were on the trial, we also collected stool samples to try and see if there's anything in the immune system. We haven't analyzed those yet, but that could be interesting in seeing if there's something going on there that correlates with response and non-response. And I'm personally super interested in if I think we were talking about this previously in our meetings of if people have allergies and their immune systems are ramped up, how do they respond to this sort of therapy? So I think those sort of analyses would be super interesting as well.
Yeah. Well, Michael, you can talk. We'll hear more about the microbiome later, but we sadly had to trim the budget a bit for our new partners who weren't necessarily interested in us looking at everything, but I remain interested in the microbiome. It is, and I think that might be actually just a study of normal people. Maybe. Okay. The Michaels. maybe we should just do a study, or maybe we should add to Katrine Whitson study, the study that now that we can have the survivors do fiber with microbiome before and after. Why don't we add the autoantibodies to that too?
Yeah, possible.
No, but we can get them.
Yeah,
Prospectively. I mean, why don't we add that? Are we just starting that up again? What's that? But I can't hear you. But
it's been really challenging to get the IOB approved.
But it is approved now, right?
Yeah, but for blood spot collection, right?
No, not for. I mean, you could do autoantibody. They're not going to. They just thought CSCs were a drug. That's all.
Oh, I know, but now you.
I mean, listen. This is
maybe, yeah.
The IRB is not the leading light here. Adding in, we're getting the autoantibodies anyway. I think that's actually really, really interesting. I love that. I love that idea. So that's low hanging fruit. Okay, fantastic. All right, so now you've heard about high risk lesions and I-SPY, and you've heard about low risk lesions and I-SPY. Now, high risk lesions and I-SPY. I mean, what I just came up with a new acronym for it. What is it? Yes, I emailed you and Zen. Dare DCIS to regress. Dare to regress. Okay. But maybe a little work. Anyway, but it's not bad. Okay. See, DAIRE. Anyway, dare with little I. Okay. Now we have our resident artist, Josh, who's going to tell us about how is it that you can get to big DCIS and not have it be invasive? What is going on? Is there a clue? And Josh, we will certainly miss all of your fantastic artistic renderings and thoughtful birthday cards and otherwise appreciation cards.
Thank you.
Very well done this year. We love that.
Hi, everybody.
Hi, Marcus. A little bit of appreciation goes a long way.
Hi, everybody. I'm Joshua Barkin. And one of the things I learned from the internship this year, and mostly about my project itself, is while our environment influences us, we really get to choose the environment, or we define our environment, and we get to choose what we really get out of it. So what my project is we're looking at the differences between high risk DCIS and biology matched invasive cancers. And kind of the question here is, how are these DCIS getting so large, yet they're not progressing, and how are they different from invasive cancers? So you learned a little bit about DCIS already from Thomas, and I'm going to go over a little bit briefly and more focus on the parts I will be touching on. So with DCIS, with these large high-risk DCIS, sometimes you see them contained in the ducts as a clean vial, as you can see on the top, but sometimes it's like a cracked vial. And the question is there something predisposing already, like this cracked vial, that leads to more reoccurrences down the road? And the question is it the vial that is causing these invasive reoccurrences? Is it the area around the vial? Is it the DCIS itself that allows it to break out of the glass? So the first thing we looked at was our defense cohort. These are these large high-risk DCIS that I was mentioning. We then compared them to the ID cohort. These are recurrent IDC cases where these patients had a past history of DCIS. The next cohort we looked at, and the one that you've heard about already, is the I-SPY cohort. These are these high-risk IDC cases. And yeah, we're really looking at what separates the defense to these invasive cases. So our first step of analysis, what we looked at was internally in our defense cohort. In our entire cohort of 52, 7 cases had a reoccurrence. And we looked at genes that were already present in the DCIS that was associated with these reoccurrences. And some of the genes we looked at are stroma and tumor microenvironment signaling genes, basically trying to identify what is this glass and the area around the glass that defines these DCIS. The reason why I have right now the receptor subtypes shown here is to show that when we were comparing these samples, that our data is very, we're not just comparing the differences between two different receptor types, that it is evenly distributed between the ones that had reoccurrences and our entire cohort. Next, what we looked at was comparing this gene expression data between our DCIS to the IDC of the ID cohort. And something to point out here is when we were comparing it, we had to actually adjust for covariance. So for example, the MammaPrint and Blueprint, as you can see here, they are not identical in both cohorts. So we're making sure that when we were comparing this gene expression, that we're just not asking the question of, oh, what is the difference between low and high risk? We're actually asking the question, what is the difference between our DCIS and our IDC? So, oh yeah, and then the last one we looked at was this immune imaging data, comparing our DCIS with our ID. And this is kind of what it looks like. As you can see, the yellow dots are tumor cells and the green dots are immune cells. And I will explain kind of the differences that we see later on. So jumping straight in, we looked at a snapshot in time of the area around our DCIS and also our invasive cancers. And the main point of this slide is to really emphasize that we're not claiming causation, but a lot of associations, because we can't prove that having the certain groundwork caused this DCIS to progress. And so that's something really important, but it's still important information for us to know so that we can look at causation down the line. Okay. So the first thing we looked at within our defense cohort is we were looking at the extracellular matrix genes. These are basically the glass bottle that you see. And out of 973 ECM genes, we found NID1 and some collagen genes to be positively associated with cases that eventually had a reoccurrence. We also found the negative association of the anchor protein LAMB2. This is basically showing that there's a loss of anchorage in our DCIS and more collagen that's surrounding it. And these are in the cases that eventually had a reoccurrence. And so this is basically like collagen glue trying to clean or fix these cracks, but it's obviously not working. And it's almost a way to identify that the cracks are so bad that the body's trying to fix it in some way with the collagen. The next thing we looked at were fibroblasts. So these are essentially the construction workers of the collagen of the extracellular matrix. And in our DCIS associated with reoccurrences, out of the 4 fibroblast signatures we looked at, there's one that was positively associated, this D cancer-associated fibroblast. And what this fibroblast is associated with is invasive growth, remodeling the extracellular matrix, and helping cancer survive and spread. So these are basically like the construction workers that are working on this glass bottle, trying to fix it up, but obviously they're not doing a good job. They're adding more pressure, they're placing things wrong, and might actually be causing a more problem. But once again, we're not claiming causation. This is an association. Okay. The last thing we looked at within our defense cohort were the cytokines. You heard a little bit about this from Chaelee when she was talking about the immune system related to DCIS. And out of the 145 cytokine genes that we looked at, the ones that were positively associated, or the one that was positively associated with cases that had reoccurrences was IL-20. This is related to inflammation. And the one that was negatively associated was HGF, which is related to wound healing. And what this is really showing is that there's a lot of warning signals that are already going off in the DCIS before there's a reoccurrence down the line. And it's basically saying, hey, there's something wrong here. Immune system, can you please come by and help out? But as you'll see later, the immune system, it almost looks like it's not doing much. The next thing we looked at, right, is this is seen in just the defense and just in the DCIS cases before they had reoccurrences. Now we want to show that this is still seen in the invasive cases when they're actually there. So this is now the gene expression data that we're comparing, and we use a gene set enrichment analysis. So basically comparing the two cohorts and seeing the differences in those genes, what hallmark or what gene sets are most prominent. And what you might expect is that enriched in the IDC cohort, the ID cohort, compared to DCIS, you see a lot of inflammation signaling. So the interferon signalings, inflammation response, allograft rejection, this is really showing that there's a lot of inflammation that is going on. And that is very similar to what we saw with our DCIS, our defense cohort previously. But in this case, it is in the invasive cases, and it's a bunch of warning signals. But once again, no one's removing, these immune cells aren't removing the invasive cancer. So the next thing we looked at is to actually physically see what is going on with the immune cells. And so this is where we compared our defense cohort to our I-SPY cohort using the imaging data. So what we found is we found a loss of immune organization in IDC. Originally in the DCIS, you see these B cell, T cell organization as a tertiary lymphoid-like structure. This is basically the immune cells setting up camp right outside the DCIS. Even though they're not infiltrating, they're right next to it and they're on standby. So if anything tries to seep out, they can attack it immediately. But what happens in IDC, and what is essentially more in the IDC cases we saw, is the loss of this tertiary structures. We saw, even though there was more immune tumor colocalization, you also see the increase of PDL1 and PD1, which Chaelee talked about as a way for the tumor to suppress the immune cells. Now in the image, you can see in the DCIS, you see the clumps of the green cells, these immune cells, and there's almost kind of like an organization to them, even though they're not spread within the tumor. But when you look at the IDC cases, they are spread throughout, but they're still being suppressed because of this PD1, PDL1 plus association. So in conclusion, DCIS is not IDCs, right? We really show that there's a difference between these cases when looking at the defense and what kind of set the stage. We saw that there's an altered ECM. We saw there's more cancer-associated fibroblast signatures in the ones that eventually have reoccurrences. When we looked at the invasive cancers themselves, we saw an increased inflammation signatures, and we also saw the loss of immune organization. So there's this loss of an organized response against the DCIS that is lost in IDC, that's present in DCIS previously. And what this is really showing is that, should we really be treating the DCIS as IDC? And the question that we're hinting at is no, because there's different things, different mechanisms going on, and there might be better approaches for us. So here's some acknowledgements. I really wanted to thank all my mentors. This has been such an exciting time and one of the definitely best years I've had in my life. So yeah, thank you. And
I see you have your hand up.
No, no, no.
Okay. Okay. So I think go ahead, ask Rachel now, make a comment.
So do you have any thoughts on how you could kind of pick out chicken and egg, which is causing the tumors to progress? Is it the extracellular matrix, or is it something they're secreting?
Remote.
Yeah, there's a lot of things and a lot of questions we still have to answer. But that is a lot of the questions, right? Is it what's already present there before the DCIS, or present there while the DCIS is there that eventually causes the recurrence, right? Like the extracellular matrix, like you mentioned, the cytokines, or is it something that eventually is changed from the DCIS to become invasive that changes the environment around it? So kind of to, I guess, answer that question is we don't really know right now, because a lot of associations, but we hope to eventually show what that kind of causation is, but it could be both.
You know what my favorite topic is?
Hypoxia?
Yeah.
Yeah. Yeah.
So,
I do think it's interesting that that this really is very supportive of our concept that there's something really important to learn from these big bad DCIS, who we call the worst, but really they're the best because somehow the body is maintaining them at this kind of big, they're not allowing a big invasive cancer to grow, and it's really working hard. And that's the clue. And so while the organization of the immune cells is not great, it's better than it is when it's invasive. That's what you're saying, right?
Yeah, that even though there's only 7 of those 52 cases that had a reoccurrence that we had recorded, and we were kind of showing that there is already a separation between the ones that will recur and the majority of them that are these large high risks that don't actually become invasive.
And so what we need to do is figure out how to just double down on that to make the DCIS go away, which you heard about in Chaeelee's presentation, but try and think about how to take those lessons forward into I-SPY. And after Sandy's question, you can think about any ideas.
So, as we talked about, I'm intrigued by your metaphor of the glass vial. But given what we know about myoepithelial cells, which glass bottle is best in terms of having the best outcome, and which is not as good?
Yeah, I mean, that's a great question. So what he's pointing at is sometimes having a super intact bottle might not be super helpful for your body, for your DCIS. There's been some studies that have found that a tighter myoepithelial layer actually leads to worse outcomes for patients. And the leading theory behind that is it's not allowing your immune system to be challenged by these cells. So kind of a leakier barrier, but not too leaky, allows some of the DCIS to seep out, the immune system to identify it and get rid of them. But if that layer is so strong that they don't even know that they exist there, the moment that DCIS figures out how to get out, there's nothing there stopping it, and it just goes wild.
One last question, which I haven't brought up in a while, which is GDF15, which is this is a molecule that can be cleaved and secreted and be in the environment and cause immunosuppression. And I'm wondering, we know we can't see it on the cell surface, but with the Hyperion, could we see that in the stroma? Because we didn't, is that on our list? It's on the panel, right? Have they put the machine in yet?
It's getting closer.
I'm meeting with the chancellor on the 7th, just letting you know. So they've got to the 7th to get it in, or it's too bad. All right, fantastic. Round of applause. And again, Halloween makes the grade, and as well as all of the scientific celebrations. Okay, so next up, between you and lunch, what could be better than talking about the microbiome? Michael Choi, come on up.
Good morning, everybody. I'll try to make this very fast. You guys can all go to lunch. My name is Michael, and I'll be presenting on the microbiome and its role in breast cancer. So as we move through treatment and risk stratification, I want to bring everybody's attention to an underappreciated yet possibly revolutionary biomarker and predictive tool, the microbiome. But before that, I'd like to share just one thing that I learned from this year, kind of a cop out, but innovation truly can come from anywhere and from anyone. It just takes a little courage to be critical of how things have been done. And I think this entire cohort of interns have been incredibly, exceptionally courageous in, taking lead in their projects and asking what could be done differently. And, aside from my colleagues, of course, the patients that we all work with continue to impress us at, asking why we do something the way we do and if we can be doing better. All right. So the microbiome, what is it? It's the diverse collection of microorganisms like bacteria, fungi, viruses that call our bodies their home. Everybody's microbiome is unique, like our fingerprint, and each part of the body can host its own microbiome, from the skin to the gut to the breast. The microbiome is essential for digestion, vitamin production, immune regulation, and defense against harmful pathogens. Ongoing research has highlighted the importance of the microbiome in overall health, with dysbiosis implicated in digestive disorders, autoimmune conditions, and cancer. Multiple different factors such as diet and lifestyle can also alter the microbiome, which makes it an attractive target for therapeutic and research purposes. The Yeah, the microbiome is suggested to play a complex role in the development of cancer, progression, and response to treatment, and therefore holds promise as both a biomarker for predicting treatment responses and as a direct therapeutic target. Identifying specific microbial signatures associated with favorable outcomes can guide individualized treatment strategies. So today, I'd like to walk you through a couple trials hosted by the Breast Care Center that aim to understand the microbiome at different points of the breast care continuum. First, we are starting to profile the microbiome at diagnosis and treatment using the I-SPY 2.2 neoadjuvant trial. This is an optional sub-study that patients can opt into. After completing a dietary and lifestyle survey, patients will collect stool samples using one of two methods, either a manual swab or an automated device installed into their toilet. Samples are collected prior to and throughout block A of treatment on the I-SPY trial. Samples are then mailed back for sequencing and analysis. This study is beginning to enroll patients, hopefully later this summer or fall. And we hope to have data later on to answer how the microbiome might be linked to treatment response, adverse events, or clinical characteristics of their tumor. Oops, sorry. All right. So now let's move later down the timeline into surgery. In the US, over 150,000 breast reconstructive procedures are performed annually. Of those, the majority are implant-based due to a faster procedure and less downtime. However, it is well documented that implant-based reconstruction comes with a high risk of complications, namely that of an infection, which ranges from 10 to 20%, but even higher in the context of known comorbidities and risk factors such as radiation. These infections can lead to potential failure of the implant and delays to adjuvant treatment. Changes to the microbiome have been associated with postoperative outcomes, largely in the context of GI surgery, but its influences are not well defined in breast reconstruction. Therefore, we designed a two-arm randomized control trial enrolling women planning to undergo mastectomy with immediate implant-based breast reconstruction. After randomization to one of two antibiotic duration arms, either receiving 24 hours or 7 days worth of post-operative antibiotics, we collect 4 different sample types: a stool sample preoperatively within 3 days prior to surgery, and then post-operatively 1 to 2 weeks, skin swabs on the day of their surgery of the breast, tissue samples collected intraoperatively, and then prosthetic fluid collected weekly either from their surgical drains or directly aspirated from their expander port. So before I get into a little bit of data, I wanted to walk everyone through just a couple of terms. So first we have alpha diversity, which measures the evenness and richness of the bacteria within a single sample. You can see that on the right, the garden representing alpha diversity may have different species and numbers of that plant. On the flip side, oops, oh my goodness. Oops, I'm gonna go back really fast. All right. On the flip side, beta diversity measures the similarity and differences between multiple. Is that better? Okay. Am I too loud? I'm pretty loud, aren't I? Between multiple samples. So now we're comparing the types of different plants and numbers between multiple gardens. Sorry about that, by the way. In these graphs, which I'll go over, you can see infection development on the x-axis and alpha diversity on the y-axis. Here we're looking at the change in alpha diversity between pre and post-operative stool samples. Infection development was associated with significant reductions in gut microbiome alpha diversity following surgery. Infected patients showed consistently lower post to preoperative ratios across multiple diversity metrics compared to non-infected patients. 2 taxa from the Bacillotophyllum showed greater post-operative depletion and greater depletion in infected patients compared to non-infected patients. I'm not even trying to pronounce those genera, but both of these declined following surgery in the context of infection. These findings suggest that post-operative infection may selectively deplete specific gut bacteria, potentially exacerbating microbiome disruption beyond the overall reduction in alpha diversity. We can also use this database for additional insights into the relationship between the microbiome and malignancy. So now we're looking at the microbiomes in breast tissue stratified by mastectomy indication, i.e. whether a tissue or lesion was present in that breast. We can see that therapeutic breast tissue is modestly less diverse than prophylactic tissue, suggesting that the diseased breast may harbor an altered microbiome with increased abundance. On the left side, we're looking at a volcano plot of bacteria that are more highly represented in therapeutic versus prophylactic breasts. We can see that breast tissue undergoing therapeutic strategies enriched for several genera, suggesting that cancer is associated with a distinct microbiome in the diseased breast. However, interestingly, in a slight departure from previous reports, we don't observe a difference in stool diversity between those with versus without cancer. Cancer status doesn't seem to have any effect on baseline stool microbial diversity. This may reflect our limited population, as only women who underwent immediate implant-based reconstruction were included in the study, and we also have not yet further stratified our study or our patients by pathological details such as invasive versus in situ disease and then treatment history. And so our main takeaways from the study were that patients with breast cancer may have lower microbial diversity, and patients who develop infections display greater decreases in diversity, and modifying diversity through antibiotic use or other methods may prove key to improving rates of infections. However, further work needs to be done to investigate the linkage between breast cancer, neoadjuvant therapy, and reconstructive outcomes. All right, and lastly, now I want to take a look at the microbiome in breast cancer survivors. The microbiome has been suggested to play a role in breast cancer recurrence and long-term side effects of treatment like fatigue. Modifying one's behavior through exercise or diet, namely a high fiber diet, can increase the presence of beneficial bacteria and their products. Many foods actually are great sources of fiber, from beans to veggies to seeds. However, we lack a lot of data on the efficacy of dietary intervention to modify the microbiomes of our survivors. So in collaboration with the Whiteson Lab at UC Irvine, we are conducting a fiber intervention study for breast cancer survivors. Anybody who is at least 6 months out from treatment is eligible. This is a study with 3 weeks of active participation. Participants will track their daily dietary and fiber consumption. They'll start fiber intervention with chia seeds starting week 2 through week 3. They'll be asked to collect 4 stool samples per week, along with blood samples during week 1 and week 2. And just be on the lookout. We are starting to approach patients in the BCC to invite them to participate. And we highly encourage you to, forward the study to anybody you think might be interested in participating. All right. So as we continue to expand our knowledge and, ability to use the microbiome for good, I just want to thank everybody who's been through this with me since day one. This includes, of course, my mentors, Laura, Dr. Piper, Mike Campbell, Katrine Whiteson at UC Irvine. Of course, all the staff, both here working in the clinics hard that I, work with on a daily basis. Of course, all the interns, you guys know who you are. I'm sorry I have no pictures, but you guys are all amazing. If I didn't love what I was doing on a daily basis, I wouldn't be here for 3 years. Okay, I love what I do. So yeah, thank you.
Well, Michael was super prominently in all the other slides. So anyway, I think this is such exciting work, and I'm so excited you're doing it. And saying here is people who know me, I've been enamored of the microbiome for a decade and a half at least. We should have given Missing Microbes as our book to read this year. Anyway, so I think this work is really exciting, and I'm serious. I think we should do in the survivorship study, we should look for autoantibodies. Think about it. The Michael should talk. Yes. Okay. Jill.
Hey, Michael. Great talk. I'm just curious about your study in the post-implant infection group with the ones where you said they had no cancer. Are you talking about people who have absolutely never had cancer, or the people who had no cancer at the present?
No cancer at present. Very few patients actually had a prior diagnosis of cancer. But yeah, for the most part, those are patients when we stratified, we looked at whether they had a diagnosis of cancer at the time of surgery.
Yeah, because you would imagine that there still is a probably some kind of dysbiosis still going on, maybe even in people whose cancer have been cured, right?
Possibly.
Yeah.
But perhaps the most important thing about this is that you've shown in the reconstruction setting that there isn't an advantage for long-term antibiotics.
There is not.
There is not.
There is no indication for a longer antibiotic prophylaxis duration.
But as you know, plastic surgeons around the country love their antibiotics and are going to be very reluctant to get rid of them.
Yep.
The good thing, I think the thing that will get them to quit is to be able to show that it's harmful to their microbiome, and that is bad for cancer. And I think if we take that fact, you'll
Exactly.
win.
No, I agree with you. Yeah, survey was done within maybe like a decade or so ago, showing that majority of surgeons will continue giving at least a week or two of antibiotics, most giving until time of drain duration, which can be, way too long.
Yeah, so I think it's really important that that you make that case to say if there isn't an advantage, and in fact you might be causing harm, it's got to stop.
Yep.
I mean, but also, yeah, causes. Did you show actually that it increases resistance also?
No, we haven't shown that. So looking at resistant sort of strains of bacteria does require higher resolution sequencing. For the purposes of this study, we opted in for 16S RNA sequencing just due to cost and the number of samples that we submit. But pending future analysis of our studies thus far, definitely, yeah, we can consider higher resolution sequencing from metagenomic shotgun to whole genome even if necessary.
Well, shall we all go improve our microbiome by eating healthy food with some fiber? Oh, wait, we have one question from Jackie.
Great job, Michael. I was just wondering if there's any known, I'm just thinking of like the leaky gut, and we know that there's bacteria that are that promote like healthy tight junction protein regulation, like bifidobacterium and such. Yep. Do we know a bacteria that can create, quote, like a leaky gut in the ducts that can either be procancerous?
I don't know of any in particular. I think that's a great point of future investigation. Yeah. I think that will require a lot more in vitro studies of the breasts and the microbiome, how they interact with one another. For example, I want to bring this up. Hans Cleaver's lab over at Hubert Institute in Netherlands has developed a culture of intestinal organoids with the microbiome. And I think it's possible, and we should definitely look into doing the same with breast.
Talk to Jennifer. Very good. All right. Now, question, can people leave their computers and things here?
This room will not be attended, so if you want, there's going to be a lot of traffic.
And the guards are out there. So it's good. Now with the new security, which is weapons and chemical inspection. So new since the San Francisco general event. So you can leave your computers here, I think is okay. And then we're walking over to Kebab. Paulo Francesca de las Alas. And great. We'll see you back here in an hour. 105, 110. Food that are going to make your immune system work better. You'll be awake and alert for the second half of our fabulous presentations. We're going to start the afternoon by focusing a little bit more on decision support and supportive care, which of course is the whole reason we gather all this information is to be able to summarize it and to show people and to help people participate in their care. I think that an activated person, someone who really understands what their issues are, and they can choose to do things or not, but they should understand what and why. But now this afternoon, you're going to learn all kinds of things on the other side, which is, how we, what the whole care journey is about, how we focus in on groups of people who have special needs. Everyone has special needs, but there are certain groups that have common needs, like young women, and really in trying to think about how we make trials more accessible. How are we doing it in a way that it's open to everyone? And it's not just about, we've learned that lesson through all of our trials and through Wisdom. It's a lot to do with who your investigators are, who you're collaborating with in the community, how you're presenting information in a way that feels safe and accessible to other people. So, and then we'll follow up with the anchor. So we've gone from treating high-risk invasive cancer to trying to figure out these tumors that are in the middle, the way station, either with risk or not with risk to go on to invasive cancer. And then at the end, how do we think about cancer interception and how do we get it down to understanding who's got what risk and how do we do a better job of managing the population? Okay, so again, many thanks to all of the mentors. Again, thanks for everyone who's come and listened to all this. I want, if Amy Babel is online, she's not, but we'll try her maybe at the end. Again, thank her for her support. I also want to thank Hope Timberlake. Big round of applause for Hope Timberlake. So Hope was, I think, person number 2 that I hired at the breast care center. She was the daughter of a friend of my brother-in-law's college roommate. Anyway, so that's some who they met at a baseball game, and Chris Kurlick said to me, "Wow, I met this amazing person. You should hire her." So I called her up and I went, "Oh, she is amazing." Anyway, so she worked with me for many years, and then she went on to start her own company about communication. And so, as all things in the vortex, it's very hard to leave. It's like the Hotel California. Anyway, so she has maintained her role in helping people do a better job of public speaking, do a better job of how to synthesize complex information in simpler ways to really get your information and your ideas across, which you will use throughout the year. So anyway, many thanks to her. And thanks for organizing lunch, Francesca de la Sala. Hear from you in a little bit. Okay, so yeah, so we have many other things that we're going to do this afternoon. So hang on to your hats. First up is Alondra Camarena. She's going to talk about mapping the patient care journey. Okay.
Good afternoon, everyone. I'm Alondra Camarena, and I'll be presenting on mapping the patient care journey at the Breast Care Center. First, the most important lesson I learned this year is to never be comfortable in medicine. Every patient experience is an opportunity to ask yourself, how can we do better for the next patient? So I want to start off with a patient story that really became the starting point for this whole project. It's impossible to me that I'm learning more on Facebook than from doctors. I feel like UCSF must have this information, yet it's not being disclosed. What stood out to me was a disconnect between what was available and what the patient was experiencing. From the system's perspective, much of that information already existed, but from the patient perspective, information felt missing. So I describe this problem as missing but knowable information. Patients often experience gaps in understanding despite the fact that this information exists. And when patients don't have the information that they need, it can contribute to anxiety, uncertainty, distress from feeling that information is being withheld, and also feeling that they're navigating their care journey alone. So the main takeaway is that we don't have an information gap, we have a delivery gap. The issue is that the information isn't reaching patients when they need it. And the challenge is improving how educational information is organized, delivered, and connected to the patient experience at the BCC. So this isn't a new problem. Presented on a similar topic for my presentation last year. Last year I worked with Mitonomy, a third-party system to implement a patient education workflow. And while the platform offered a mechanism to deliver the materials, the content didn't meet BCC standards, and we ran into barriers to customize content. And one of the key takeaways from that project was highlighting that the BCC already has great high-quality educational materials that meets our standards. However, information is scattered, there's no standard delivery workflow of the information, and the content doesn't align with the patient care journey. So the question has since evolved to, how do we better organize and deliver what already exists? And that's what I'm hoping to tackle. So if the problem is delivery, what does a solution look like? If we have the information at the BCC, how can we make a delivery content system out of it? And the framework that I've been using to think about this solution comes from DK Kemper's concept of information theory, the right information to the right person at the right time. It was sounding pretty familiar from Alyssa's presentation this morning. It's a simple statement, but operationalizing it is something I'm hoping to break down. So the approach, how do we do this in a patient-centered manner? My project proposes using a patient journey map as the foundation to do this. The goal is to develop a detailed map of the patient care journey at the BCC, because if we're trying to determine what information should be delivered and who should receive it and when should it be delivered, we need to understand, or we need to have a clear understanding of the journey itself. So using the patient journey map allows us to think through each component in the information therapy framework. First piece, the right information, something we're already in a good position for. The opportunity lies in the other two dimensions, the right person, needing to identify what educational materials are most needed and useful, and at the right time, defining touch points where information is most relevant. And the patient journey map provides a foundation to tackle those questions. So first step in this whole project is to develop the patient journey map. Sounds easier said than done. There's a lot of workflow processes in the BCC, but just to kind of give you an overview of what I did to approach, kind of 5 big buckets: awareness, diagnosis, treatment planning, treatment, survivorship, and follow-up. And while I won't go through all the intricate details, the goal was to understand the patient experience, where decision happens, where transitions occur, and where patients might need additional guidance. And the journey map then became a backbone for designing educational workflows. So first step. Second step is to, or once we have the patient journey, the next question becomes, what information is most needed? So we're currently conducting a broader needs assessment that includes literature review and conversations with patients and providers. We conducted an environmental scope of existing educational information. And as an initial step, we wanted to leverage an existing source of patient-generated information, and that led us to the PSC question lists. For those who don't know, Patient Support Corps, we offer 2 main services, one of those being question listing services, where we brainstorm questions with the patient and document them so that the patient feels prepared for their appointment. So with these pre-visit questions, the keywords capture questions that patients are asking as they prepare for their first appointment. And my goal in reviewing this was to identify common informational needs and then think what educational materials could address those needs. So it provides a real world snapshot of these informational needs before patients even enter the clinic, i.e. a touch point opportunity in the patient journey. As one example from surgical oncology, patients commonly ask about understanding their diagnosis, choosing between surgical options, and understanding next steps. So here's an example from surgical oncology. We can then translate these questions into targeted educational opportunities. What's important is that these questions can be translated into actual educational materials that can then be delivered before the patient reaches certain touch points in the patient journey. For example, patients making surgical decisions about, surgical decisions may benefit from decision support materials like comparing lumpectomy and mastectomy. Which we have this information, it's on our website. It's just a matter of getting the information to the patient at the right time. So then we have part 1, part 2, we put it all together. What do we get? Part 3, third step, at the right time. Final step is timing. So once we understand the journey and identify educational needs, we can begin mapping educational materials to specific touch points. We could start thinking proactively about what information is most relevant. So rather than asking patients to do a web search or resource center on their own, the information can be delivered in the moments where it's most relevant. For example, here I mapped information from the BCC website. Those are the links, just to kind of give you guys an overview of what that would look like. And this transforms educational materials from a static document existing on a website into part of the care workflow now that we've kind of mapped it all together. So if successful, the work can have impact on multiple levels. For patients, it improves understanding, reduces uncertainty, and helps patients feel more comfortable throughout their care. For providers, it creates a more efficient way to prescribe educational materials and spend more time on focusing on aspects personalized to the patient's health. And for the health system, it better leverages resources we already have while supporting patient-centered and education standards. So an interesting finding that emerged from the analysis that kind of ties this all together is that across specialties, the most persistent theme that was coming up from the questions that patients were asking as they progressed through their care journey was uncertainty about what happens next. So in building the patient roadmap, it became not only useful for designing educational workflows, it also can become a patient-facing resource that helps patients understand what they can expect in their care journey. So this is an example of what kind of the mapping of the patient journey could then turn into as a patient-facing resource. So to recap, we have great quality materials. The challenge is just delivery. And the patient journey mapping provides a framework to connect existing content to the patients at the right time. And our early findings suggest that patients might not or are looking not only for answers to specific questions, but also understanding their overall care journey. So the next step is so this was just a blueprint. We actually have to do this now and put the action into place. And one of the pillars that's really important to me is making sure that these informational materials are then translated to languages other than English. So call to action. As we develop this work, I'd really appreciate all of your guys' input, specifically on high priority educational topics, key patient touch points, ideas for workflow integration, and existing materials we could incorporate into a content management system. And reminder to always stay patient-centered. I'd like to thank the patients and the family whose experiences inspire this work, Jeff, Laura, Francesca for all your guidance, Praveen, Aldea, Sarah, and Susie for their collaboration and knowledge on this project, and to my fellow BCC intern peers, you guys are amazing. Thank you.
We are very lucky to have our next breast surgery fellow, Praveen, who's super interested in this topic. And he's already been put to work, which Jeff thought was usurious, but he in fact contacted us. So before I got a chance to even ask him, which I would have anyway. But anyway, I want to put this in perspective. Remember Project Health Design? I think that was like 2002 when we did the survey of what people wanted most is people wanted to know where they were in their journey. And the most important thing, where's Trinity? On the One Source project, just reminding Adam, the most important thing when you get the diagnosis together, just doing the order of therapy, whether even the trials work out that way, just even something really simple, just making sure people know where that is so they know about what's coming down and when anyone answers the phone or calls them, that they know where they are and there's a dot on where they are on that journey. That is amazingly consistent. So 26 years later, it's the same issue, right? Mm-hmm. So we obviously haven't met the need, but we will this year. Where's Trinity? All right, it's all on you. Okay, no, just and Praveen and Adam and everyone else. Okay, questions, comments? Jeff, you want to comment?
Sure. Yeah, Alondra, you covered most of the key issues in a very short time. I just want to say for everyone to be thinking about interns who are launching their careers, it's just a sad reality in fee-for-service medicine that there's no funding mechanism for patient education. So this is an institutional factor that's really hard to get around. Like I'm aware of the Mayo Clinic, I think, has a central budget for patient education. And so they actually have a pretty good department that handles this. I'm not aware of that kind of resource investment at UCSF, well, right. So, but these are institutional barriers, really. I did some consulting. I was contacted in 2015 by a wealth management firm that helps people plan for retirement, and the leader said, "Oh, what you're doing between doctors and patients is what we'd like to do. It's kind of shared decision making between advisors and people planning for retirement." And then I ended up having a bunch of conversations with bankers and wealth managers and things. And I said, well, the problem we have in healthcare is that no one is paid to talk to patients. You're paid to do procedures. You're paid to, the fee-for-service model is all about reimbursing procedures and drugs and devices and all that kind of thing. And this vice president of wealth management at Wells Fargo or whatever said, oh, I have 10,000 advisors who are paid to talk to their clients. So in other industries, they can make an investment in educating consumers because their financial model supports it. But we're in an industry where the financial model doesn't support fundamentally patient education, which is just crazy. It's crazy making. So yeah, the BCC is, yeah. So these are really important, structural issues. And I think we have to work on the kind of underlying institutional frameworks to fund things like patient education, because although individuals and even departments like the BCC can sort of make heroic efforts, it needs to be more systemic.
How do you, before you give up the microphone,
Yeah.
how do you think that education or the lack of that dovetails with the lack of prevention?
Well, yeah, they're part of the same. Yeah, that's part of the same dynamic as if fee for service is ultimately rewarding volume of procedures and volume, so that's why we have overtreatment. I mean, if you have insurance in the United States, health insurance, you're probably equal risk of being overtreated as undertreated. Now, if you don't have insurance, you're probably at more risk of being undertreated. But that's the whole overtreatment issue, right? Is that volume drives revenue. I could go on for this for a long time, but yeah, I'll yield the mic now.
We'll start our own healthcare system. Yeah.
Alondra, this is really great. And I love how patient-centered you are in literally every aspect of what you do at the BCC. And I know you also do a lot of work at the VA. And I was just wondering if there were any observations you have between patient education at those two institutions.
Yes, great question. The project at the VA focuses on helping veterans better understand decision making for genetic testing. And a lot of that is the intervention, which is an educational material. And I think one of the aspects that I really like about the VA is how they think about different patient needs. For example, a lot of veterans aren't comfortable with technology. So they make it a point to offer a printed resource that is mailed out to the patients instead of just online. So I think that is...
Some of our older patients actually requested that. That's why we brought back the BCC information sheets.
Exactly. Thanks, Annabelle.
And Vanessa, you're going to fill in all the gaps in the treasure map, right?
Yes.
Okay, good. Yeah. Everyone's going to have a role. It's going to be our big team project this year, right, Alondra?
Yes.
Big round of applause. Okay, next on our supportive care journey, Simona Krasnegor is going to talk to us about the Young Women's Support Group and her reflections on why or how this is actually helpful to young women.
All right. Hi, everyone. Good afternoon.
Everyone's awake. 7th inning stretch.
Yes. Well, a critical component of the patient care journey is psychosocial support. And one of the key support resources we have at the Breast Care Center is the Young Women's Support Group. Over the past 2 years, the support group has been one of the programs I've been the most grateful to be a part of. It taught me that, for me, connecting deeply with patients can be a huge source of resiliency. This is why for my presentation, I wanted to focus on the patient population of our support group so that we can better understand how we can expand this resource for more patients in need. The Young Women's Support Group is available for women diagnosed with early stage breast cancer, stages 1 through 3, and are under 45 years old. They can join the group as long as they've been diagnosed within the past 3 years. Each group consists of about 12 to 15 women and occurs in the fall and then again in the spring. The group itself is via Zoom with an option for in-person first and last meetings based off group interest, and includes mindfulness meditations, group discussions, and guest speakers on topics especially relevant to young women, including fertility, sexual health, and treatment-induced menopause. Eligible patients are enrolled in a few different ways: referrals from providers, social workers, even interns, cold MyChart messaging, and also patient outreach through the UCSF website. Of those that consent to join the group, a subset also agree to participate in research surveys that are given before, immediately after, and 6 months following the group. These surveys include questions about demographics, but also promise measures of psychosocial health. Looking at overall statistics for our group, the first is age. The median age at group entry was 39 years old, with most patients being from 35 to 45 years old. White, Middle Eastern, and Asian individuals are well represented in the group, with about 56% of our patients reporting their race as white or Middle Eastern and 25% as Asian. 15% of our patients identified as Hispanic or Latina, and 80% reported that they were in relationships. Our patient population is highly educated, with 39% receiving a college degree as their highest education level and almost 46% having a graduate degree. Almost 66% of our patients also reported an annual income of over $100,000 a year. In terms of employment, 35% of our patients were working full-time at baseline and 13% were working part-time. Nearly half of our patients' primary health insurance provider was through their employer. Out of 8 total sessions, the median group attendance was 5 sessions. Most of our patients attended at least 5 groups, but as you can see, there was a great amount of variability present, with 10 people attending no groups at all. Geographically, the vast majority of our patients were from San Francisco and the Bay Area as a whole. Interestingly, we have had more regional patients than local patients, and even 19% joined from outside of the Bay Area entirely. Our statistical analyses found that there were no significant associations between group attendance and age, race, location, education level, annual income, employment, health insurance, or marital status at baseline. However, Hispanic and Latina participants attended significantly fewer groups than their counterparts. Vital to understanding these results is understanding our population as a whole. The demographic composition of the group is reflective of the broader demographic composition of the patient population we see at the breast care center. Our patients were highly educated, high income earners, and had a small proportion of racial minority groups. This limits the generalizability of our data and points the need to meet our most vulnerable patients where they're at. This means not only ensuring these patients are educated on the availability of this resource, but also connecting them with social work so that they're supported holistically, whether it be transportation, childcare, or medical or disability leave that can help with the added treatment burden. Additionally, although our analyses did not find significant associations with these demographic factors, they still remain extremely vital in clinical decision-making. Our findings highlight the nuance of the decision to seek support and show that it's very highly individualized and isn't strongly affected by one single demographic factor. Overall, our findings suggest that the group is broadly accessible to a diverse demographic, and the lower attendance among Hispanic and Latina participants highlights the need to prioritize culturally responsive outreach, both before the group and support strategies within the group itself to increase attendance. In the future, the support group will continue to underscore the need to recruit diverse patients and expand access to research in our underrepresented groups. Future work should also focus on our follow-up data and adding patient-reported outcomes that are also measured in the surveys amongst different demographic groups and attendance rates so we can gain a more holistic view about all of our patients, including greater insight into our Hispanic Latina population. Moving forward, these findings point to three main directions. The first, expanding psychosocial support to encompass more patients and creating more groups for year-round access around breast clinic sites. The second is targeting outreach to patients who need the most psychosocial support and to those that may feel marginalized. And third, practicing culturally sensitive education to make all patients feel that they have the resources to get every type of support that they need. These women share common fears, trauma, and social stressors that can be mitigated by peer support, even when done virtually. The support group is a welcoming and accessible resource, and our goal is for it to be accessible as possible for patients of all backgrounds. I want to give the biggest thank you to our patients for allowing me to learn from their stories and for their ongoing participation in both the group itself and the research. I also want to thank the group facilitators, Debbie and Kiara, and lastly to my incredible and inspiring mentors, Dr. Jo Chen and Laura Esserman, for the creation of this resource and their ongoing support, both for me and our patients. Thank you.
Simona, we really want to thank you really for your service, not just for organizing and doing this, but when our social worker left, you were filling in and being basically our social support service pursuant to the comments that Jeff made earlier. But so you guys do make a difference in me and Dia. Big shoes to fill here. So, and it's so amazing to have the ongoing interaction and participation of Debbie Hamalski, who was the first nurse that I hired in the BCC in 1993. And again, retired now 8-9 years, but you can't really leave, as I said before. So questions from the audience and comments. I also, wanted to, as you've also done a lot of the work on the cold caps, and that I assume, but I don't know that that hair, that keeping your hair is probably something that's particularly important to young women. But I don't know that. I mean, you've had that experience of being with young and old, and is it sort of independent of age, or is it really particularly important?
It's a good question. I think young women.
Explain what that is to the rest of the news.
Explain the cold caps. Yeah, so cold caps are essentially a treatment strategy we use during chemotherapy to help people retain their hair. Most chemotherapies cause nearly complete hair loss, and some even carry a risk of permanent hair loss. So cold caps are meant to reduce that amount of hair loss, we hope. And then to answer your question, I think it depends on a lot of factors. I think when I have spoken to young women anecdotally, the biggest reason they choose to undergo cold cap therapy is mainly for their children. So I think it depends largely on the factors of how much, everyone's very individual, how much they see their hair as being part of their identity, how much, the types of people that they surround themselves by, whether it's young children or family members or at work. And so it's really nuanced, and also different people have different amount of value to their identity tied to their hair. Some people prefer to shave it all off and not do the extra 2 hours of treatment time and the actual extra cold discomfort. So, I have seen it more in young women. I would say it's more because of their either professions or their children or the reasons why.
And privacy.
Privacy, yeah. In those, yeah,
is a big thing. Okay.
Yeah, I was just wondering, this is really great, Simona, and I was just wondering, if you could pick one resource or thing to have offered to all of the young women at UCSF with breast cancer, what would be the number one thing that you feel like is most important to either maintain or change or improve?
That's a great question. I think, if I were to say for the breast care center as a whole, I would say making sure that we have social work very deeply integrated into kind of how we're able to note what people need and when, and kind of having this web, because not everybody wants peer support. But everybody wants to feel supported, whether that's in their own lives or from their physician themselves. And so I think the biggest resource is probably patient education on what resources we have so that they can make the decisions for themselves, and provider education on what resources we have so that if those conversations come up, they can be connected to the right people.
I think probably another important thing is, especially with Erin starting, taking over for what Mindy used to do, but really, I think expanding this, which is, if you're suffering from symptoms and feeling like what even perception of estrogen deprivation, that may or may not be what's causing your symptoms. But the idea again is, we know that's an issue. We hear you. We support you. I think we need to try and make that a little more integrated. I think I've forgotten who's taking. I think Dia, who's taking the lead on. Yes, that the other issue is, what I perceive is that the people that we need a better way to identify people who are really feeling like they're going to fall off the cliff.
Yeah.
And that's really what the new part of, it's just carrying on what we've done, but trying to do that. How can the organization of the BCC help us? I have everyone sort of working to contribute to say, I think I'm worried about so-and-so, and then alerting, the team.
This is where I'm going to do some shameless promo for the Breast Cancer Cafe, because it's something that we work with PSC, where we cold message people, and they're able to see it 3 days after their appointment. And hopefully we get a new social worker, and I'm not the social worker anymore, but we have a social worker, med-onc nurse, surgery nurse, and it's a resource for people. Join all the time. They're like, I don't really know what I'm looking for, what I need, but I just wanted to listen. And all of those people leave with valuable information about not only their treatment, but also what resources we have. We send messages to everyone that attend of resources that we talked about in the group. And I think that because providers have so little time to go over all of those resources, we need kind of just a safety net for patients who feel like they're not being heard. And I think that the cafe is a huge resource that I really hope can continue and catch those patients.
Definitely. And it reminds me of what Alondra said, right? What I have heard, we've had all versions of this, as everybody knows. I brought out the notebooks a few months ago that we gave to everybody that had all the resources in it. The problem comes down to, when do you introduce that? When people are first diagnosed, they're just like, and that it's like, how do you get people, when do you reintroduce that information, and how do you get it back? But I think the cafe is open for people ongoing, right?
Yeah, it's from stage 0 to stage 4 at any point of diagnosis and treatment. And I think that the language of the advertisements of the group kind of reflect that, that it's just a place that if you're feeling like you might have additional questions, you want to hear from others, it can be a space for anything, anything at all.
Great. Okay, you good? Okay, thank you so much, Simona. Okay. And then next, we have Venezia, who's going to talk to us about expanding access to trials, but why language really isn't enough to help make trials accessible. A lesson we learned in the Wisdom trial for sure, but I think that's true for all trials. So Venezia, by the way, Venezia next year is doing the treasure map. So anyway, you can explain that.
Yes, definitely.
We'll leave it like that. All right. Hello, everyone. My name is Venezia Garza, and my biggest takeaway from my first year here at the BCC is that while clinical trials might be, quote, tomorrow's treatment today, the full extent of these clinical trials, the full impact of these clinical trials will never be felt if they're not both informed by and benefiting our entire patient community. And so I'm here today to discuss why one particular subsect of this patient community, Latina Spanish-speaking patients, have been historically underrepresented in clinical trials, and what we can all do as a community here at the BCC and as a field of oncology to bring them in so that they too can feel the impact and the benefits of the incredible clinical trials we're hearing about today. So for the past year, I have been working with breastcancertrials.org. It's a clinical trial matching platform that connects patients with clinical trials that are best suited for both their breast cancer and lifestyle needs. There are various different filtration options that patients can sort through to make sure that they're reading about and learning about trials in patient-friendly language that are most applicable to them and their particular needs. And while this platform has been incredibly effective at connecting patients with clinical trials over its almost 30 years in existence, it's still missing one key patient population, as is the larger field of oncology. Latina patients represent approximately 10% of all patients with cancer. However, they only make up around 2% of clinical trial participants. And this is not factoring in the language component, in which Latina Spanish-speaking patients likely make up significantly less. And so it's important in this manner to think about what can we do to begin bridging these gaps and expanding access. The first part of our project this year was phase 1, translating all of the resources and the materials within breastcancertrials.org into Spanish. This, I might say, was the easy part, even though sometimes translation can be challenging. This was one such educational pamphlet that I translated, a myths versus fact sheet, to help better educate Spanish-speaking patients about what are the myths about clinical trials and what are some of the concrete facts, and how can we make sure patients know the difference between the two. However, if it were that easy, then we would just translate all of our resources and all of our pamphlets into every single language and call it a day. Unfortunately, that is not the case, and it never will be. The second phase, and the phase that we're still in right now, is now expanding clinical trial education and awareness. And we can't do this alone. We leaned into our community partnerships, particularly those who had a particular focus on Latina breast cancer advocacy, and utilized their insights and their wisdom and knowledge to help create our first round of educational workshops and Q&A sessions to begin the process of expanding this information and bringing this information to Latina Spanish-speaking patients. I conducted a 60-minute clinical trial educational workshop delivered entirely in Spanish, and we outreached to 35 representatives of our breast cancer organization partners, and we conducted a pre-workshop survey to collect the existing knowledge and attitudes of registrants before attending the workshop. So we're very proud to report that we reached over 9 different cities in 5 different states, showing that even just, although the Bay Area isn't a small place, but here at the Bay Area, there's a large reach and a large need across the nation for these kinds of materials. And the results from the pre-workshop survey were incredibly interesting. While the first 2 statistics at the top were to be expected, 70% joined to learn more about clinical trials, and 60% had never used breastcancertrials.org. That we anticipated. The statistics below, 60% of registrants had been living with a breast cancer diagnosis for greater than 5 years, and around 50% reported some college education or greater, were much more revealing to us, because they also revealed to us who we perhaps didn't reach in this initial educational session. They showed us that we didn't reach patients who maybe had been newly diagnosed or were in active treatment or were otherwise healthier screening. And it also let us know that we didn't reach patients who had less than a college degree or had more limited health literacy. And for context, the remainder of registrants who answered the statistic about education elected not to answer. So there's more to unpack there as well. What this tells us as a whole is that we may need to take a step back even further than what we thought and reevaluate the ways in which we're presenting educational materials around breast cancer and around clinical trials to perhaps break it down even further so that it can be made accessible to patients across every stage of the breast cancer journey and across every level of education. We also collected some questions before the session, and 5 key themes emerged: types of clinical trials, the enrollment process, costs and coverage, trial duration, and navigation and support. What this tells us is that there was really no one particular theme or large area that patients wanted to learn more about, but rather they really wanted to get a sense of the broader scope of what it means to participate in clinical trials. And finally, the results from our pre-workshop survey revealed some really interesting barriers and opportunities that we hope to explore further. On the barrier side, 60% reported that they were not likely to enroll in a clinical trial at the pre-workshop time point, and 70% did not feel represented in clinical trials. These are incredibly nuanced data points, and we hope to expand and explore these further, but they could also be cyclical in nature. If patients don't feel represented in clinical trials, that might inform why they might not want to enroll in one, amongst many other things. However, there was one really interesting opportunity that emerged from this preliminary data, is that approximately 70% reported that they were likely to discuss clinical trials with providers. This puts providers in a key point to serve as a bridge, as a point of connection between patients who might just need an introduction or a push into clinical trials to consider them as routine options of care for themselves. And so some takeaways from this first year of work and leading us into the next year is the importance of targeted outreach. We really want to make sure that we're reaching within the Latina Spanish-speaking community every type of patient and making sure that the materials that we're promoting and that we're using to educate these patients are made accessible to folks across backgrounds. Second, the power of patient-provider discussion. To all the providers here in this room and who may be on Zoom, you all serve as a key point in every patient's journey and could potentially serve as a key point in Latina Spanish-speaking patients' journeys. And we hope to better understand further what this patient-provider dynamic and relationship looks like in future focus groups. And finally, expanding access extends beyond translation. If it were as easy as just translating, we would already have incredibly diverse clinical trials and incredibly diverse outcomes from these clinical trials, but it's not. It requires people, it requires a community. And that's why for our next steps, we want to talk to more patients and we want to conduct focus groups to discuss these barriers in greater detail, to better understand what are both the practical and social changes that we can make to bridge these barriers to participation. We also are very grateful to have received some grant funding to professionally translate the breastcancertrials.org website. And we're working to establish a Spanish clinical trial navigator, myself, to help guide patients through the clinical trial navigation process. Once again, it's not enough just to have the translated website with the translated information. We need to have people, navigators, providers, clinic staff there to guide patients through every step of the journey. And so with that, once again, while clinical trials may be tomorrow's treatment today, we're still struggling to get yesterday's treatment or today's treatment to Latina Spanish-speaking patients and patients of other minority groups. And so we can't do this alone. We need you all. I would invite you to join us in this work. We're always open to new individuals joining the breastcancertrials.org team. And I just want to say thank you to the incredible mentorship and guidance I've received from Sabrina, Jasmine, Lisa, and Susan. Thank you for encouraging me and continuing to pursue this passion to expand clinical trials to Latina Spanish-speaking patients. And to the greater BCC community, all the teams with which I've been involved in, clinic staff, the mission hall staff, thank you for an incredible year.
This is a great example of when you pick your final project, it doesn't have to be in the work that you're doing. It can be something that you learn about. And this is actually developed by Ellie Cohen and myself and Dubutropathy forever ago. And it was one of the things that got expanded out by the NCI, by the Cancer Biomarker Informatics Grid. That was the first thing that they really expanded. Now they wanted to show that they didn't have to keep supporting the things that they built, which was kind of unfortunate. But anyway, we managed to keep it alive and keep working on it. But it is part of Quantum Leap. Quantum Leap is our not-for-profit collaborator and sponsor of I-SPY and Recast and clinicaltrials.gov, but it is something that when we wanted to take it and turn it over to the public, that's kind of not necessarily the work of the university. That's the work of sort of a group like that. Anyway, and of course, thank you for your salsa classes, which will continue this year. Anyway, so questions, comments from anybody here. I would say, Alison, this is sort of one of the things that, I found very interesting about people notice that they feel unrepresented by the people who are in the trials. As Kim Badal likes to say, no participation, no representation. And I really like that phrase. And I think it's a good way to try and get people. And I think that there is, while they're frustrated that they don't see themselves in the trials, they're also fearful and sometimes reticent because and not trusting because it doesn't include them. So it's chicken and the egg, right?
It is. And I think one of the larger contexts that the BCT team and I are working under is decades of systemic inequity, of systemic exclusion of minority groups in clinical trials and in medical spaces, the medical mistrust that has been sown into these communities. We're fighting back against all of these different barriers and walls that have been put up over decades. And so all that to say is we have our work cut out for us, but it will be worth it.
You know what? We should have her present a forum.
Yeah, no, that would be great. Our community forums that we have once a month, the next one's on Monday.
Okay. I'll be ready.
Where we try to bring some of this information and findings back to the community and give them an opportunity to talk to and ask questions of the research team. So bi-directional communications. Yeah.
Thanks, Allison.
Okay, so the first question from the chat is, what is something that Venezia learned about the community's particular needs in this work?
Yeah, I think we're hoping to learn more specifically about what the needs are from the focus groups. Right now, from this preliminary pre-workshop data, we kind of just got a sense of where are people at right now. But in these focus group discussions, we want to unpack why is it that they are at where they're at now? What is motivating them to feel certain ways? And so I think it's a great segue into asking particular questions about further knowledge and attitudes about clinical trials in these focus groups.
There's another question. For the education attainment question, did you count some college outside the US or only accounted for completing college within the US?
That's an excellent question. We didn't go into such detail within the actual survey questions, but that would be something really interesting to look at perhaps in future educational sessions. I think one particular nuance to the data was that just because because the majority of our patients had some level of college education background, that might have also informed why they might feel more comfortable discussing clinical trials with providers. And so I think it'll be interesting to explore further, but to answer the question, no, we didn't particularly specify whether it was college in the US or out of the US.
Most of the surveys just say, how many years of education have you had? We don't really ask where you got it. We assume it's good wherever you got it. Unlike, well.
Thank you all.
Okay, and now we're going to go on to talking about prevention. And all this work about trying to figure out how to, how to do a better job of figuring out who's at risk and how to make sure they don't ever get cancer. And to tell you a little bit about that and about our trial, Emily is going to talk to us. Emily Smith's going to tell us a little bit about give us a little introduction for all of you about what the wisdom study really is, and then all the work she's been trying to do to figure out who followed the recommendations.
Hi, thank you, everyone. Well, ask and you shall receive. Thank you so much, Laura, for the introduction, and Venezia for the wonderful presentation to follow up. As Venezia just mentioned, It's so important to champion inclusion and accessibility and all the innovation we push forward. And that's why today I'm going to mention before I hop in the biggest lesson I learned. I think it's so important to fight that fear of starting something new, going against the grain, or even just standing up for the right thing. And I think that's exactly what we're doing here with Wisdom as we try to change breast cancer screening across the country. Great. And before I hop in, I just wanted to go over some important terminology. You'll hear me talking about adherence and mammograms. Just so we're all on the same page, adherence in healthcare, we talk about a patient or a participant following and being active, having an informed commitment to a prescribed plan. And mammograms are a low-dose X-ray of the breast used to detect and diagnose cancer. I'll be talking about screening and diagnostic mammograms, so here's the difference. Great. So breast cancer is not a single disease, and the way we treat it today is complex and personalized. The best treatment plan greatly differs depending on a person's tumor type, and so they look at molecular subtype, staging, biomarkers. So why are we still doing screening as if it's one size fits all? And this is exactly where Wisdom was born, this idea that all women should receive a personalized screening recommendation based on their personalized risk. And so Wisdom 1.0 was launched to compare risk-based screening with annual screening. And the way we do this is in the risk-based cohort, the women who are in the risk base, we get their mammogram information, including their breast density, their health questionnaire data, including like family history, biopsy history, age, race, everything you can think of. And then finally, their genomic profiling. And we use this to create a screening assignment that's based on personalized risk. And so for example, if you're low risk, you might not be told to screen until you're 50. Whereas if you're kind of higher on the risk scale, we can tell you to screen every 6 months, alternating mammograms and MRIs. So this is the screening assignment letter that you might get if you're a participant. The first part is the screening assignment. Here you can see on like the circle. And below you'll see the report that they submitted prior. And so the study will actually calculate, based on your screening assignment, the next possible date that you could get a mammogram from their recommendations. And I was pulled into this work when Laura pulled me in the hall and she's like, we need to check if people are following their screening assignments. And so this is what I'll be calling adherence.
Careful where you're standing.
Yes, very careful where you stand. The hallway's a dangerous place at the BCC. And so we analyzed this using the National Committee for Quality Assurance. Their guidelines are benchmarks for quality assurance. And they define adherence for breast cancer screening as 6 months before or 6 months after the recommended date. And so with this in mind, came the hard part of creating a binary logic that kind of encompasses all the scenarios of adherence. And so I first went on and defined what an on year and an off year is. An on year is whenever Wisdom recommends the participant to get a mammogram. And so in this case, it would be a mammogram within that timeline is adherent. And if there's no report or if it's out of that timeline, it'd be inadherent. And then an off year would be when Wisdom doesn't recommend a mammogram. And so the logic kind of switches in that scenario. For example, someone who is on an off year would be like a participant who's 2 year, every other year of their participation would be an off year. Great. And so the challenges. So Wisdom 1.0, we reached so many women and we had over 250,000 mammograms submitted to us. And so data cleaning was so difficult, but it was very rewarding to see how many women sent us in their mammograms. And so as you can imagine, within the 250,000 mammograms, some are self-reported, some are from medical reports. And then you get all these duplicate reports of a woman who, let's say, reported the same mammogram 3 times, but it's based on memory. So let's say they reported a mammogram, but they're like 3 days apart. And so now you have to parse through whether this is an actual follow-up mammogram or if this is just incorrect dating. And another thing is with such a big study, you're going to have a lot of missingness to account for. Not everyone's actively engaged, or life comes up and they might not give us a mammogram or a report. And so it's kind of filling in the spaces backwards and seeing what we can kind of piece together from this huge data set. Great. And so we were able to do all this, and then the results didn't come without their own critiques. Overall adherence in year 1 was around 48%. And then the percentage of women following their screening actually steadily declines throughout the study. And this was one of our Wisdom 1.0's biggest feedback of the study. And it's a hurdle we should overcome as we think about future implementation. If we want women to follow wisdom everywhere, we should understand what the barriers are and how we can better adherence. And so I went back to the drawing board because adherence should be informative. And so the simple yes/no of a binary analysis doesn't really tell you the context of why someone's following or not following an assignment. So I switched over to this multivariate analysis, which codes for over and miss screening. And it stratifies each participation into like a type of adherence. And then even further, we had to find who aren't we analyzing? And so there's a good number of people who we don't expect to get mammograms anymore, right? Women with breast cancer diagnosis through the study. Maybe they had a prophylactic mastectomy. They don't have tissue anymore to do the mammograms. There's also limited participation where women with a stable risk that doesn't change, we don't give them screening assignments anymore. So we shouldn't, knock those people for not getting mammograms. And then the hardest part was, defining what loss to follow-up is. Women who are unreachable and disengaged in the study, they're neither logging in or seeing the screening assignments anymore. So counting them truly as inadherent would be kind of not reflective to the women who are choosing to not follow our screening assignments. And so I'm happy to say we reran it because we don't give up at the BCC. And adherence actually stays consistent. And so what we found was within the risk-based group, adherence actually consistently sticks around this 49% mark. And compared to the annual, it's actually higher than the annual adherence. And we go one step further because we excel at the BCC. And you can see how the trends kind of are consistent compared to before. But then we can also see insight into what these specific groups need. So for example, this is the low risk group. And in this group, it's actually over-screening that defines their inadherence. And so that kind of points us to, is this because of conflicting recommendations? Is this because providers and participants are having those discussions? Or is it because of a lack of trust? Are they screening more than we recommend because they don't trust our recommendations? These are all things that we should be thinking about. And that points us specifically to potential solutions, making the risk report more accessible so they can talk to their provider, or maybe incorporating them into the electronic health databases like Apex so that they can actually access them in appointments. And then this is actually different when you go to like the average group, for example, their inadherence is marked by misscreening. And so that kind of changes what kind of interventions we would want to, go forward and do for that group. And so that would be, is it a difficult interface? Are we missing reports because they don't want to, submit them? Or is it hard to submit them? And that would point towards potential solutions that are done different again. It would be improving completion of the yearly follow-up, or maybe systems to remind people of their appointments, or even uploading their mammograms. And I'm so happy to see my wisdom team in the crowd here. Thank you guys for coming. But I'm so proud to say that our team is actually reflected on this data, and they're actively making a difference having seen this data. I see Irene in the crowd here, but she's been championing this partnership with Medicom to rely more on medical records than self-reports. And someday we'll get mammograms to be auto-collected rather than self-reported. And that should also help get a better understanding of what adherence truly is. And then going forward in the future, we'll also be asking participants directly how they interpreted their assignments and how they've then used them and talked about them to better understand how we can then support wisdom, make it wiser, and make it more accessible for women everywhere. I just want to thank all my team. I've had a wonderful year at the BCC, and it's been such a growth opportunity, and I can't wait to be here for another year. Thank you.
One of the things I was thinking about as you presented this, and I'm sure we thought about this, was
when you talked about the 250,000 mammograms that have been reported, we actually didn't sort of look and say what's the expected number of mammograms we would expect it to be reported if people were adhering on
pure
either
number.
side.
Yeah.
And we haven't done that analysis yet.
We have no idea.
Why don't we?
We should.
That seems like I was like, oh, I bet
That
we
would have
haven't
been
done
a
that
good
yet.
first base.
No, that's why it takes a presentation like this, like, oh, wait, why don't we just do the simple thing? Yeah. I mean, that alone would be, I think that will tell you we're probably missing a bunch anyway, which we know anyway now. Okay, comments. Yes, Jeff.
Thanks. Great work. You guys are doing such an amazing job presenting so clearly. I do want to provoke you to maybe think about flipping the, what's the word? The orientation of your findings so that you talk about, instead of talking about patients adhering with recommendations or not, you could talk about whether the recommendations align with what patients are doing. And the reason I'm suggesting that is just that medicine just has this, long tradition of paternalism where, we sort of set the standard, or we, meaning collectively, medical complex sets the standard, and then we want to see whether people adhere to our standard. Whereas maybe looking at it, positioning it the opposite way would be a bit more of a person-centered and humble approach to, like, okay, do our recommendations actually align with what people do when they vote with their feet?
When we gave the recommendations, what did people do without using the word adhere? It's not a great word. I agree, but we just didn't have. But I think that's a really good suggestion.
It may even change the math. I haven't thought it through, but like
I don't think it'll change the math, but
yeah, it might change.
But the one thing that I don't understand, I mean, not which I know that probably the people who adhere the most closely are the people with the highest risk groups, and the way we know that is because the number of biopsies. We have, and actually. We do, I mean, whether it's, we're probably not capturing as well, but if you look at the number of mammograms by risk group, the most, or the number of screening events, the most are in the high risk group, the elevated risk group. I mean, that's only 2% of the population, but that's true. And also the number of biopsies are way high. So I think maybe Jeff's right. There may be a different way that we can frame it, because we know that they're getting more imaging, they are getting more biopsies, and their chance of stage 2B cancers are also quite a bit lower. So, I mean, they didn't have any of them. So the elevated risk group did, but it's just, I think, I mean, the trial's pragmatic, which is also, people just don't quite get that. That means you're just, yeah, it's pragmatic. So we weren't having people come in and measure when we weren't regimenting it. We were just saying, hey, we're making the recommendation, we're going to see what happens. But just because we can't see it happening doesn't mean it's not happening.
Yeah, I was going to ask, it's a randomized trial, but it's preference tolerant, which means we have participants who chose to be in the risk-based group. We even have some that chose to be in the standard every year starting at 40, and one question would be, which group is more adherent or less adherent of those three, and in fact which direction, so is someone who is less invested in the trial but agrees to sign up, doesn't want to be randomized, wants to do the same thing they've been doing every year at 40, are they actually even coming in for their annual mammogram? Who knows? I mean, I think you've got the data. It's good questions.
We haven't actually done it in the non-randomized group yet, have we? No.
The non-randomized? No, we have. Yeah. I have that data. I can share it.
Okay. Fortunately, this is a big work in progress, and you'll be here to do more of it. And inquiring minds want to know it. But I think that's a very good suggestion. I like that suggestion, Jeff. And I think there might be another way for us to think about that high risk group and their adherence based on biopsies and the number of mammograms they got somehow.
Well, thank you, Jeff. Great.
Okay, thank you. Okay, moving right along with wisdom. Olivia Cooper has been working with Kim Badal and really trying to help us answer a question that so many women care about, which is, what about my lifetime exposure, and is that increasing my risk? Welcome, Olivia.
Hi, everyone. This is my second presentation. It's my second year, and I didn't make a very pretty what I learned slide, so I'll just say it off the cuff. But I definitely learned that trying something and learning why it doesn't work and failing, as Jeff has been reframing for us, that failing is not a bad thing, is really an essential part of the learning and the research process. And sometimes good things can take a really long time to come together. I do that. So, in general, when we think about environmental exposures, people, it's very sensitive mouse pad, sorry. Okay. But really want to understand it. I feel like every conference we go to, people talk about chemicals that are risk of breast cancer. But we can't really do that if we don't have a consistent way to measure it. And in the context of risk, it's really important to also be able to utilize that as well. And so we're really lucky here that we have the Wisdom study, which is already a risk-based breast cancer screening study. And so within some Wisdom participants, we did a little estimate there. Okay, so there's been a lot of research about environmental exposures in breast cancer. And so far, we know that exposures to these elements at work might increase your risk. So there have been a lot of studies with night shift workers, so sorry to all the physicians out there, nurses, flight attendants, anyone who's working late at night and interrupting your circadian schedule, toxic chemicals, so nail salon workers and domestic workers are exposed to a lot of different chemical exposures. Ionizing radiation we knew is a problem, so military personnel, nuclear plant personnel, actually flight attendants again. But ultimately, it can take 20 years for breast cancer to develop. And so being able to understand these exposures over the course of time, not just in one moment, is really important. So we need to find a way to quantify people's exposure history over the course of their entire life. Our study question. So Americans spend over 35% of their lives at work. So we chose to start there. It was the easiest to quantify. We're also doing some research on residences as well. So there are a few different reasons why occupational exposures are difficult to measure. The first is time, right? So people work all kinds of jobs for varying different lengths of time. There's also, of course, temporal factors. If you happen to be working somewhere when there was a very large disaster, that can impact your exposure. Variation, exposures can vary from job to job, right? So if you're working at a nursing home versus in a hospital, it's a different level and different types of exposures, even though they're qualified under the same job. And we thought about a lot of different ways to do this. The standard is interviews, but the Wisdom study is about 70,000 women strong. So that times 30-minute interviews would take us a very, very long time. We also thought about chart review, but as Emily mentioned, chart review can be really difficult, just like in the Wisdom study, because there's missing information and incomplete data collection there. So our first goal was to figure out if this actually already exists before we went across validating this, and we didn't find anything that exists for the American context. So we developed the workplace history questionnaire, tested the reliability and validity, and then incorporated participant feedback. Let's go to the next one. Oh, it's opening Slack, sorry. Okay, next slide. So yes, this is just a data collection flowchart. Again, we have 70,000-ish women in Wisdom, at least when I made this chart. We contacted recently active participants. We reached about 40 of them that were interested, randomly selected and invited a diverse group. 28 completed the questionnaire and 27 completed the interview with the occupational health expert. And amongst our key results, overall, the work queue showed moderate to excellent agreement with the expert interview, which is what we were hoping for. Agreement improved when jobs were grouped into broader categories, like going from RN to NP as nurse, right, and not specifying. Start and end years for jobs were nearly perfect. And first degree family history of breast cancer was also highly consistent. I think likely similar to the high risk participants in Wisdom, they're very motivated to accurately participate. And finally, participants ages 50 to 59 had the strongest agreement. So overall, it can accurately collect job and family history through the self-reported questionnaire. So again, this is a great thing because it fills a methodological gap. It enables cumulative exposure assessment, right? We need to be able to gather these jobs over the course of a lifetime, both cumulatively but also temporally. And it links occupations to health outcomes, which helps us support research into the relationship between these occupations, but also other exposures in breast cancer. So our next steps, which have honestly happened, which is great, is to release the questionnaire into the Wisdom study. So almost 10,000 people have completed it now. We are then linking those participants and their histories with LexisNexis, which is a government database that allows us to access their work histories. And then finally, we're hoping to use the residential histories to match addresses of work and home to known exposures to then assess cumulative exposure history. And one thing that was new for me this year is that I worked on Rise Up. And so I really enjoyed session 10, which Kim and Peggy co-chaired. But they talked a lot about this as well at Rise Up and some takeaways that the questionnaire is also associated with. So we talk a lot in Wisdom about how many chances in a woman's life there are for hormonal intervention. This is also totally true for chemical exposure. In this questionnaire, we're only covering prenatal and adult, but this session definitely helped me think about my project in a much broader way. And the questionnaire just isn't necessarily just an administrative tool, but it is a way to capture part of the environmental exposure story that's really missing. As you can see, there's so many different points across someone's life that they can be exposed to chemicals at various amounts. And so we really do have a lot of work to cover, and the work queue is the first step to trying to get there. And then the exposome was also greatly discussed at Rise Up. The exposome is considered a lifetime collection of environmental exposures, whereas the genome, for example, is the complete set of DNA and genes. So together, they can kind of represent the totality of someone's risk potentially. When we talk about nature and nurture, both of these concepts are at play. And so we're really hoping that if we incorporate this, we can track external exposure all the way to internal dose, biological response, and then maybe incorporate that into breast cancer risk. And so these two concepts work together to dictate a woman's health and risk for ailments like breast cancer. And again, part of why we chose work history is that a lot of the exposome is really difficult to quantify. It's really hard to measure exactly how much someone was exposed to at a certain amount of time. And so work history is something that we can gather potentially as a litmus for other exposures they may have had. Occupational exposure is also an equity issue. It kind of reminded me of what Venezia was saying with clinical trials. We talked a lot about occupations with higher level of exposures, but certain occupations are actually incredibly hard to track exposures in. So nurses, firefighters, nail salon workers, domestic workers, I discussed. But as I was writing our paper, there's a lot of talk about farm workers, which is a very highly transient job. They are often for very short periods of time and can be incredibly difficult to explain how environmental exposure risk might be occurring here. They are often underrepresented in epidemiological research. These jobs are high mobility. The job histories are extremely complex. And it can be really difficult to identify specific workplace exposures just from specific job to job. It's also that traditional research methods may just miss or fail to capture exposure histories accurately. So this continues to reinforce why administered tools like the work queue matter, because they can help us collect occupational histories from groups who are often left out of environmental exposure research. And this is why our next step matters. So the questionnaire is not an endpoint. It is a tool that'll help us collect these histories, but then we hope to integrate many different types of assessment, including DNA methylation and mixture analysis as well, to really try to understand how environmental exposures, both at work and at home, may be influencing breast cancer risk. And I'm very grateful to the wisdom participants who participated, and to all the staff here at the BCC who came and who are also not here. I'd like to thank Kim, my mentor, and Luna, who helped a ton with the data analysis, Dr. Van Veer, Peggy, Laura, and of course, Francesca and the interns. So thank you very much.
Well, as you can see, Olivia is also the Canva queen. So I don't know who's going to take up the mantle for that.
Venezia's giving me a run for my money. She's pretty good.
Okay. I realize that there's one we're missing, reproductive years. You got to add someone.
Yes.
That's like a big, you went.
That's a good one. I skipped right over that.
Yeah. And the really elderly, we can do bone health for that. So move that.
I was looking for the original slide and I couldn't find your original.
Where is that?
I don't know where it is. Emily and I were both looking for it for our presentation. So
it's somewhere in the OneDrive morass.
Deep in box. Who knows?
All right. Questions for Olivia. I think so, Olivia, I think just as we learned earlier on in the morning segment that, one of the ways you make progress is to really understand the biomarkers, and understand which groups are at risk for what. And that's where you can maybe instead of looking across everyone, you might miss the signal. Yeah. So why is it particularly important to look at these exposures in wisdom?
Yeah, so, exposures, if they contribute to risk, they're especially important for women who are at particular high risk. We don't necessarily know to what degree these exposures have an impact, right? But if you're already a high risk woman, this could be something that could be really helpful for you. If they do have a great impact, be really helpful if you're low risk. The nice thing I think that, speaking to advocates and people at this exposure conference I went to is that it does give people a bit of an element of control, right? And if it feels good to be able to avoid something like Teflon dishes and all these things. And so if you're especially high risk and we can figure out that matters, then we can give people actionable things to do as well, which I think is
if you're really low risk, you don't have to change your stove.
Yes. Tupperware is fine. Who knows?
Slowly moving to glass. I've not gotten to the new stove yet.
Yes.
Working on it. Too late for me. Okay. Any other questions? Fantastic. So great. Thank you so much, Olivia. Wow, we are in the home stretch. Okay, we have just a couple more. Everyone stand up. You jumping jacks. 7th inning stretch. Excellent. Do a little salsa move. Okay, all right, perfect. All right, that's enough. Okay. All right, so moving on with our theme, one of the most interesting questions. Sandy, this is for you. Okay.
It's all about me.
It's all about you, yeah. And so we want to know, who is at risk for what kind of cancer? And in the wisdom study, are we able to figure out who has been diagnosed with indolent cancers, where we can worry less about that, and which groups did they get assigned to? So without further ado, Daisy Montoya, take it away.
Good afternoon, everyone. My name is Daisy Montoya, and the most important thing I learned this year was keeping in theme with accessibility is that advancing science is not just about developing new technologies or finding new biomarkers. It's about bringing people along with us. And these people aren't just providers, staff, it's also our community organizations, our community members, and making sure that, thanks, making sure that they're also being represented as we've been hearing in these past few presentations as well. And so, there you go. And so as we've learned, this extends beyond screening, as we've learned with the wisdom study. It's detecting a cancer is only the first step. When we think of better ways to identify which cancers are truly harmful, we need to know which ones are what Laura likes to call the killer cancers, right? But we often don't know the difference between something that is a killer cancer and not a killer cancer. So the wisdom study, as we've so heard from Emily, is built on this foundation that screening is not a one size fits all, and the same thing can be said about breast cancer. Breast cancers exist on a spectrum, and as we can see with the graph right here, some grow quickly and can cross the threshold of symptoms and mortality. Others grow a bit more slowly, and there are also those that grow very slowly to a point that they may never reach the threshold of mortality or symptoms. And this is what we then call overdiagnosis, or more accurately, overtreatment. And so screening allows us to detect cancers earlier, but this also means that we detect cancers with very different biological behaviors. And so tumor grade is used to describe how quickly a breast tumor is likely to grow and spread. And so many cancers that appear low grade or slow growing, which are the ones highlighted here in grade 1 and 2, are the ones that can progress and cause harm. And in fact, because these cancers are so common, many breast cancer deaths occur in women with cancers that would traditionally be considered lower risk. And so I want to make an important distinction before moving forward between slow growing cancers and these indolent cancers that I'll be talking about. They're not interchangeable terms. As we can see here, slow growing cancers can be harmful, and slow growing only refers to, as I mentioned with tumor grade, the rate of growth. It doesn't tell us whether that cancer will eventually become life-threatening or not. And so these slow growing cancers that may require treatment can progress over time, but the ones I want to focus on are the indolent cancers that are a little bit different. They represent non-harmful cancers that are unlikely to cause symptoms or threaten a patient's life. And so these can take years to progress and may actually never become clinically significant, which is why just knowing if something is slow growing does not mean that you are safe. And so if having slow growing doesn't mean that you're safe, then this brings us to what our real question is. So the goal is not simply to identify slow growing cancers. The goal is to identify cancers that are truly indolent, the ones that are unlikely to threaten a patient's life. And if we could identify these cancers reliably, we can avoid overtreatment in this subgroup of people. And unfortunately, the problem is that today's clinical tools do not distinguish these groups well enough. And if you can't identify them, well, you can't change their treatment. And this brings us to what we know today. We know that there's a group that is truly indolent, a subset of women with ultra low risk breast cancer. And these cancers, as actually published by our dear Laura herself, showed that there's extremely favorable outcomes over decades of follow-up using a molecular assay by identifying these group of women who their risk of dying from breast cancer over the next 20 years was actually exceedingly low, hence the ultra low risk subgroup term. And so with this, we don't have to prove that indolent cancers exist. Again, we know that they do. They're called ultra low risk. But the issue is, how do we identify these ultra low risk breast cancers in a scalable manner? And how do we intervene at the right time so that they don't get overtreated? It simply doesn't help, again, to know that there's ultra low risk cancers when we can't tell them apart, because patients also don't want to be undertreated. And so the WISDOM study is working on tools to help us find them using the WISDOM cohort for a population level implementation. And if we want to identify these indolent cancers at a larger scale, we need more efficient approaches beyond just molecular assays. And so how do we solve this in the WISDOM study? Well, we're looking into whether pathology-based approaches combined with AI can help identify these indolent cancers. And this is really where our project begins. We want to determine whether pathology, images, and AI can help identify the same ultra low risk cancers that molecular testing identifies, but in a faster, more scalable, and potentially less expensive way. And so to make this possible, we developed a patient-centered workflow that allows us to obtain pathology slides and tissue specimens from our wisdom participants. And that will eventually allow us to both characterize and understand the different biology types within our wisdom cohort and further enable personalization beyond screening, which involves treatment and future risk predictions. And so to do this, we first focused on building the participant workflow, which involves getting permission from participants to access their tissue. And so the way they do this is by opting into this project, and they'll be signing a release of information that we can then use to fax their pathology departments that will mail us those tissue slides, and we'll be able to analyze them. And these pathology images will be analyzed primarily through a central review of pathology, some immunohistochemistry, digital analysis, and potentially AI models and other pathology techniques for analysis. And so the Wisdom study has tracked all those who have reported a biopsy or a surgery. And with this, we'll begin a small pilot at UCSF of approximately 70 participants who are eligible. This means that they were either diagnosed with DCIS, invasive breast cancer, or other qualifying lesions as well that we'll be looking into, such as atypia and LCIS, which is lobular carcinoma in situ. And during this time, we'll be able to evaluate not only enrollment, but also some operational metrics such as turnaround time, sample retrieval, participant engagement, and all this is essentially to allow us to refine our workflow before being able to expand to all other sites and capture the whole Wisdom cohort. And soon enough, we will have sample slides to show, right, Sandy? We're working on it. But with that, ultimately, I want to share that this is not just about collecting pathology slides. It's about what those slides really will enable us to do. We know, again, that truly indolent breast cancers do exist, but we currently lack scalable methods to identify them. And by building this pathology collection infrastructure within the Wisdom study, we'll be able to create this foundation for applying pathology and AI tools to further characterize breast tumors and distinguish indolent cancers from those that may require more aggressive treatments. And at the end of the day, supporting more personalized prevention and treatment strategies, because as we all know here and has been conveyed throughout many of these presentations and sort of ending this in the same way that we started, if we cannot find the right treatment for the right person at the right time, then we are not doing a good enough job. And so if we cannot identify these indolent cancers, then we cannot personalize our treatment. And that's what we are all about here at the BCC. And so with that, I'll then want to thank everyone both within the Wisdom study and the Borowski lab, and Sandy, Anita, and especially who have been really spearheading these projects. Little shout out to our first day and last day pictures for our BCC intern cohort from last year. I want to thank Francesca and Dr. Esserman and Allison for being such great mentors within the internship and the Wisdom study, and everyone else involved in all the other projects outside of the Wisdom study. So thank you, everyone.
Great. I presume you have a comment. Resident pathologist.
Thanks for all your hard work this year.
Of course.
This is the hard part of the study, and it's not exciting yet because we don't have the results, but getting the work done is so important. It's more than just personalizing. It's more than just the right answer for the right person at the right time. It's also critical, as was my comment to Thomas, for us to do our studies correctly. If we have the wrong endpoint, if we just have cancer, yes, no, as the endpoint, then we're not doing the study correctly. So we need to know what you're trying to find out so that we can do all those other Wisdom study and
exactly
all those other studies correctly.
Yeah. And luckily I'm here for a second year. So hopefully
Yay.
next year we'll
It'll
have
be
slides.
exciting. We'll have results.
I'm just noticing that the only way I know that that's legit the last day is that Thomas is wearing something different. Okay.
And like we told him what to wear.
We did.
It was no
Or
surprise.
he didn't follow the instructions.
No, he forgot.
Maybe not. Um, so this is a really exciting project, Daisy, and this may not be a question for you specifically. It may be more for like Dr. Esserman and Dr. Borowski, but what would be the ideal treatment for these like truly indolent cancers? Is the answer no treatment, or is the answer just a surgical excision, or is that still a big question mark area?
Well, take a page from the prostate cancer group. We are doing active surveillance for DCIS. I mean, for really truly indolent cancer, it's possible that we could do that, or treat with hormone therapy. For people who are older, who have that, we do that. Although Bruce Mann actually did a presentation at the American Society of Breast Surgeons a year and a half, a little over a year ago, and actually showed that even people, I mean, it wasn't exactly with most indolent, but you still can. I mean, it's not. Listen, we don't have a perfect marker. I wish memoprint ultra low risk was perfect. I mean, the thing that's interesting is we looked at this, signature in other cancers, and it does definitely separate between low risk and high risk. It's not quite enough. And when we went back to the cohort in Sweden where people had node positive disease, you can see that ultra low risk signature. And if you had a positive node, you did worse. Not as bad as the people who didn't. So it's one of these things where it's enough. It definitely is discriminatory, but is it enough? I always like to say this. You really don't care if it's statistically significant. What you want to know is it significant to the patient? P-value should be about the patient value, right? Is this like, someone say, oh, there's a lower risk of, ctDNA and lobular versus ductal, 68 versus 83%. Really? Who cares? It's just like, it's that, it might be a little bit less, but that's not material. Or, yes, it's better, but it's 70%, 5-year survival versus 50%. Well, you're not going to leave someone at 70% and not treat them. So it's trying to figure out what are those other things, and it might be, that's one of the things I'm excited about the Path AI projects, is because there could be clues in there that if you know what the ultra low risk signature is, and then we added something that the computer is saying that we can't, that is about that stroma. I think that's something we should look at. And, I think everybody, I want to, Paul Henderson sent around that article which is so interesting, from Eric Topol's summarization of this really dense cancer cell article. You have it, right, ICC? Do you want it? I'm going to send it around. I want all the interns to read it. It's such a cool multi-pronged approach to sort of thinking about what's driving risk, what's driving the kind of cancer that shows up, what are the things that we can do, how are we going to be thinking about this in the future. It's really pretty cool.
I think it's really cool the way everything is coming together today. So earlier you said the engineers get it. They understand how to weigh risk against other risk.
It's not an accident, Sandy. You know that.
I know. Education. So we need to help educate our patients to think about risk. And so the answer to your question is, it doesn't have to be perfect the way you think of perfect. You don't have to say, we are 100% sure that your cancer is indolent, but we have to tell a patient where they fall on a scale of risk,
on a spectrum.
And we have to teach them how to think about that risk in context of their overall health and well-being. And so that's both an educational, a scientific, and a very real reflection of biology that we have to bring to personalized medicine. We're never going to be 100% sure. Your breast cancer risk is never going to go to 0%. Everybody has a little risk of dying of breast cancer, including men. The question is, how do we reduce that risk with prevention? How do we measure that risk? It's very difficult when you get diagnosed with even ultra low cancer. That is, in addition to being something we never had to find, but now that we found it, it's probably a risk marker lesion that you might develop a second cancer that might be a little different. And so we put it in the same category maybe as ADH or LCIS, which we don't think are precancers
We need to
even,
go back to the,
but they are risk marker lesions.
we need to go back to our cohort because, you know, when the finding the ultra low risk cancers, because I wanted to know what the risk of those cancers is, I got rid of everybody who had bilateral cancer. We should go back and look and see who are those people and what, you know, what they have. And I had learned early on in my career, this is shared decision making under uncertainty. You cannot promise anybody a good or a bad outcome. You know, that's just not how it works. You know, it's like all things are possible. The chance for you of it happening is much lower. Chance for you of happening might be higher. Doesn't mean you're gonna have a progression. Doesn't mean you're not gonna have it. You have to be very careful because when someone who is very low risk, it just operated on someone last week. Like, she goes, why did I get this? I said, honestly, I have absolutely no idea. You know, I sent you an email about it. Anyway, don't know, right? And so I think that's really, it's really important. And, you know, like people say, promise me I'm never going to get a recurrence. I'm like, okay, I can't really do that, but I can say it's just highly unlikely. That is actually one of the things, like, you know, that list of probable things happening. You're getting struck by lightning or being hit by a car or being hit by a car if you're in a Waymo, which is interesting. Has anyone seen that? You should appreciate this advertising. Now, Waymo is saying, like, they are advertising that they are, because they care about humans, you know, they are found to be 7 times safer than a human driving a car. So everything is relative, right? It's very interesting. It's very interesting. One of the most important, this is one of the most important things in breast cancer. This is actually what got me down the road to thinking about risk-based screening, was how to avoid finding these kinds of cancers. But we have them. We'll get there. Thank you. You're going to use your computer? Okay. Okay, and next up, we have to close it all out, right? Chaelee was our one source intern, and so she's going to give us the future of how we can build quality and outcomes, and to the future of healthcare, because if we don't know what we're doing, there's no way to improve it, and we can't learn and be better next year than we are today. Thank you, Chaelee, and thank you for coming in despite your healing needs.
Well, good afternoon, everyone. Thank you so much for coming and staying this long for the presentation. So I'm going to start off with what I learned this year during the internship. And I think the most valuable lesson that I've learned this year was that building stronger algorithms requires building a very strong foundational data, and that ends up helping us to build better outcomes. All right, let's get started. So imagine having the smartest brain in the world, but it's completely disconnected from the rest of the body. You can't see, you can't hear, you can't move. And no matter how intelligent it is, it can't really do its job. And so I believe that healthcare is facing that exact challenge today. AI is becoming incredibly powerful in this day and age, but intelligence alone is not enough. So today I'd like to show you the future of healthcare depends not only on smarter AI, but on stronger foundations, which will help us to build the quality and outcomes into the future of healthcare. So a little bit about myself. I did my background in biomedical engineering, which is really not the most important part. With this new surgery, I now have 2 cadaver ligaments supporting my 2 strong knees. I really hate bananas. They have to be slightly green. I really love pickleball, which is something I can't really do right now, so unfortunate. Obviously, eating and drinking coffee is really important for me as well. And obviously, being the one-source champion this year, so I'm really grateful for that. So the central message I have today for everyone is that healthcare does not have an intelligence problem. We all know that. Communication is now our problem. And obviously the greatest barrier into AI is not its algorithms. It's whether the right information gets to the right place at the right time. And that's the framework that we'll use today in our journey. And so we're going to look at healthcare and AI through a body framework. So AI is going to represent our brain, and the language center is going to be our LLMs. And the heart represents our clinicians, nurses, and our patients.
An eye is going to represent where AI will succeed, and a broken nerve is going to represent where it's going to fail. And the nervous system will represent one source, which will connect all of us together. And finally, the hand represents our action. So now let's begin with the brain. So what exactly is artificial intelligence? Well, it's technology that learns patterns from data and uses those patterns to make predictions or recommendations. So I want everyone to do a quick experiment with me. If I say the term peanut butter and, what would you all say? Great try, but jelly is correct. Well, obviously everyone said jelly, and that means you didn't really spend 5 minutes reasoning through your brain for every possible answer. Your brain predicted the most likely pattern. And so that's exactly what modern AI does today, just on a much larger scale. And so AI learns from examples, and the more high quality examples it becomes, the better its predictions become. An interesting fact is actually AI started 70 years ago. This term was coined by Dartmouth researcher John McCarthy. And over the next couple of years, now we're in this era of generative AI. And so the most common AI intelligence model that we use today is large language models. That includes things like ChatGPT, Gemini, and Claude. The most important distinction I'd like to make is that we are not in an age where AI understands anything. They predict the most likely token that comes next in analyzing and predicting human language. So they don't truly understand information the way humans do, but they generate the next most likely word based on billions of examples. So this is an important distinction when we're talking about healthcare and how AI can be integrated there. Part of my project, before I even start to think about how AI could be integrated into healthcare, is I wanted to know what exactly healthcare professionals thought about AI. And so now, quick show of hands, how many of you have used ChatGPT this week? Okay, wonderful. That's a lot. Now keep your hand up if you thought it was useful to you. Okay, great. Now keep your hand up if you would let ChatGPT diagnose your cancer. Okay, that's exactly what I wanted to show. Out of the 66 people that I surveyed, 95.2% believe that AI is going to be helpful in their manual workflows, in limiting administrative workflow and burden. However, the biggest concern wasn't things like job replacement or technology. It was diagnostic errors, like all of you have illustrated. So one of the respondents said that their biggest concern was obviously misinterpretation of data and giving false information based on invalid sources. And that's going to be very important. So now quickly again, now can anyone in the audience tell me what they're looking at right now? Yes, close. But the correct answer is diabetic retinopathy. Obviously, most of us can't tell that because we are not ophthalmologists, but we're going to look at a case where AI did successfully do this. So actually back in 2025, this was one of a great success story of AI where I can present. So AI systems actually trained to detect diabetic retinopathy and achieved approximately 95% sensitivity and 91% specificity across more than 13,000 patients. This study was done in 2025, and now it's an FDA-approved AI system. And this foundation and system worked because the input was very standardized retinal images, and many experts labeled thousands of examples. This task was also extremely narrow and asked one simple question: does this patient have diabetic retinopathy? AI wasn't replacing what physicians would do, but instead it was helping them to identify patients who needed care sooner. And so from this lesson, there were two specific main points that I would like to emphasize. The data was clean and the problem was well defined. And that's where AI can really succeed. But unfortunately, not every healthcare problem that we have today looks like diabetic retinopathy. So in 2010, I'd like to present a case now through the broken nerve. IBM Watson was supposed to revolutionize cancer care. Billions of dollars were invested. This vision was extremely ambitious, and more than $60 million was actually invested into this system. But despite that investment, the project was ultimately canceled before it could even achieve its goals. They spent 6 years developing this system for oncology. And even after this many years of development, they were only supporting 7 of the 12 major cancer types. And when researchers compared this system's recommendations with physicians, agreement was only 33%, which is quite a low agreement rate. And that made it very difficult for physicians to trust these recommendations consistently. And so on the side, I want to highlight 4 main things of why it failed. One, AI is only as good as the data it has learned from. So if the training data is biased, these recommendations come out as biased. Second, explainability. Clinicians couldn't always understand why the system made a recommendation. And obviously, as many of you know, in healthcare, if you can't explain a decision, then it's very hard to trust it. And third, it couldn't keep up. We're in an age where new clinical trials are constantly being made. There are new treatment guidelines, there are new FDA approvals, and AI obviously cannot keep up with this. And finally, the wrong population was targeted. Much of this system's training data came from a very small number of institutions, and that meant the recommendations didn't always generalize to patients seen at other hospitals. Now, for all of these failures did not happen because AI was not intelligent. The reason why is because the foundation underneath this AI wasn't strong enough. And so then that goes back to understanding that in this case, the brain wasn't the problem, the nervous system was. So maybe we've all kind of been asking the wrong question. The problem isn't really AI, the foundation beneath it. And so before we can start even building better AI, we have to build stronger connections. And that's what brings us to our next question. How do we build these foundations? If AI is the brain, well, then one source is going to be our nervous system. And its purpose is to connect information, bringing together data from different systems so that clinicians and eventually AI can work from the same complete picture. And the last point is AI cannot learn from data it cannot access. So if it's not accessible, how are we supposed to provide the brain with all that information? So I wanted to show kind of the trajectory of OneSource now. We are trying to build an app where we can compile all the information from different institutions for patient data. And obviously, we hope that this data can all be consolidated to one place and come in and out of Epic. So this is kind of a mock-up of what it could look like through a portal for a patient. These are all fake patients, by the way, so it's not real. But you can see that we are trying to make a very integrated system here. And so lastly, I'd like to turn all of our signals through our nervous system into action. So I wanted to show a live demonstration today of how you can use AI to create your very own live project tracker. So I'm going to quickly show how you can ask ChatGPT to make you really quick code and make that into a really fast project tracker. So this is RStudio. I think maybe some of you are very familiar with RStudio and how it can help with statistical analysis, but you can also use it to house Python, which is very useful. And so using Streamlit, maybe some of you have seen this at Sparking Innovation. It's a very nice way to visualize your data and your code. So I'm going to run what I've asked ChatGPT to do. And using a very structured Excel format, I've basically used an Excel of all these patients who are on a project tracker. And on the side, you can adjust these filters and see who you've completed, who's at risk, who's delayed. And you can also make Gantt charts. It's very easy to visualize all of your data. So if you have a very cleanly structured Excel, you can use all of these tools to create a very easy project tracker. And so back to the presentation, this is a mock-up of obviously the patient tracker that we just saw. But using all the three of these tools, I think I was able to make that project tracker in around 5 minutes yesterday. So that's a place where you could use AI and it can help you in your manual workflows. And so to close everything out, we've gone through the journey of the body from the brain all the way to the hand. Today, we've seen how AI can succeed and where AI can fail. And we've actually heard what clinicians think about AI. So the lesson today is that we don't need exactly stronger algorithms, but we need a lesson that teaches us to build stronger foundations. And foundations like these can foster quality and quantity in our outcomes and help us to understand that AI is going to support us and we can trust it later on in the future. And I wanted to say thank you to all of the people at Quantum, Jasmine, Adam, Gary, and Sai, and obviously Laura for all your mentorship through this project, and Dr. Mukhtar, who has helped me through the Flex registry, and obviously all the interns and everyone here today.
That is a beautiful demonstration of what we want OneSource to do. And I knew IBM Watson was going to fail because you can't get the data. You can't, that it's like the one thing we do know is there's a certain amount of data you have to have. And if you don't have it, doesn't matter what. And like it just to having a prompt to make sure we get all that data in as a start. But I think before everyone gets worried that AI is going to replace your jobs, the one thing AI can't do, it can't come up with ideas that aren't already in there. I mean, not yet at least. And so your job security is your ability to be creative and think about how to do things. But if you don't have the right foundation, all the creativity in the world will not help you. And it is learning how to ask the right question. Jeff, are you happy about that? All right, questions from the audience about this? Yes.
That was really great and a really good, in many ways, a really good primer for a lot of us that don't understand what's under the hood. First of all, my answer to the peanut butter question is Prozac, because my dog's on Prozac. Every morning has peanut butter and Prozac.
What have we come to?
But secondly, I think not just physicians, but patients agree. The patients I talk to recognize that AI-based tools can be good for their physicians. I've seen this in my own primary care doc uses AI-assisted notes, and it's freed up our conversation. We just talk, and her notes are done. It's great. So I think I'm in the same boat, which is, yeah, use the tools, but don't trust it to be replacing, that person that has the context that understands where we're coming from.
That's I don't think AI has empathy, but anyway, which is I think what pretends to. But I think that I remember Rachel Remen. For those of you, Kitchen Table Wisdom. I should have given out that book this year. But Rachel Remen once said to me, remember when Jeff and I had gone to her, we were going to either write a book or teach a course that said, become the physician of your dreams. Wasn't that it? Right? We were going to call it Marcus Well BMB, or I don't know, whatever it was. Become the doctor of your dreams. And she said, you think your patients like you because you know so much. That's got nothing to do with it. They like you because you care about them, and they know that. And I think that's the most, having this foundation and knowing you've got the right facts is the foundation that you have to sort of put the pieces together to individualize a care plan for each patient, put it into a map where people can understand where they're going, but then it frees you up to be creative and empathetic, right? And that's the future. All right, other comments, and you'll when you come back for Sparking Innovation next year, where's Trinity? Oh, it's all up to you. It's gonna all be implemented, right? Any other comments before Francesca and I close it up? That you are the last of the interns. Yes. Okay. And I have a question. Since you really aren't familiar with all of the work that's going on, do you have a better idea of all the stuff that's going on at the BCC now?
Yes, and incredibly impressed by all the interns' projects and presentations.
See, there it is for a completely unbiased observer. So there you go. So Jessica and I are going to close things out for you.
Yes.
And I want to say, Francesca de las Alas,
Yes.
thank you so much for all that you do every day for all the interns. For me and the Rise Up team, and what a wonderful addition you've been to our
thank
BCC
you.
family. So Francesca is going to give us the year in review.
We heard, thank you. We heard a lot of incredible presentations. It was a full day. I think it's reflective and a testament of the year that we've had. Like she said, I'm Francesca de las Salas, formerly Leung. We can talk about it later, program manager of the internship program. And our team just wanted to share a few slides that really made this internship real, where the memories made the memories meaningful, and importantly, all of the people who made it possible. A common theme in the photos was Halloween, so let's start there. This year, our interns wrote, rehearsed, and performed Cruella the Cancer and the Dalmatian T cells, and took it on the road for the first time, making rounds through the hospital, spreading genuine chaos and joy. 6 performances, 0 shame. Truly, the BCC. Now, they need fuel for their creativity, and I tracked over this past year 224 Skinny Pop bags consumed. Sea salt, the undisputed champion, the official fuel for the BCC. Data collection is still ongoing, but prelim analysis reveals its promise for being statistically significant.
I only recently found the drawer that has the stats.
Oh no.
And I had temporarily forgotten about it, but thank you for the reminder.
No intern year is complete without a legendary hike, 8 miles conquered together, 1,900 feet of elevation. There was rain in the forecast. However, we still made the trek. Thank you, Laura, for giving us courage to brace the storm. It was sprinkling. One hike, a lot of stories, a lot of sandwiches. If you can tell the middle photo, they were trying to spell out Laura, Laura. And somewhere along the way, there was enough collective energy to form our first new running club. Shout out to Kenny, Annabelle, Venezia, Josh, which they went on to compete in the SF half marathon or the marathon? Half marathon. Okay, training wheels. Something truly special about this class is their instinct for gratitude. 60 cards, all by hand. Thank you cards, birthday cards, recognition for patients, mentors, and staff. Our resident artists, Joshua, Emily, and Venezia, never needed a reason to pick up a pen. They always found one. So some of their wonderful drawings. And if you've received one of these letters, they really do mean it. And I hope this is something that we can continue for years to come.
Okay, what's going on in that picture?
Okay, Joshua might need the mic to explain this ILC. Mia, who has the mic?
That's with the dolphin or the poster?
The dolphin one or?
The dolphin and the owl and the person.
Oh, good. That's Thomas's birthday card. So that's Thomas there.
Thomas is the man.
Yes, that is the man.
Thomas is the man.
And then he's scared of an owl and a dolphin because they are having a discussion. And that's this is based off, I believe, Jeff's what is it?
Greg Hicks.
Yeah. Greg Hicks.
I relayed it to you.
Jeff relayed it to us.
Like personality.
I'm a dolphin.
Yeah, so Laura's supposed to be the dolphin and Jeff is supposed to be the owl.
Dolphin.
Laura wants me to be a dolphin, but I'm really not.
Dolphin.
He is.
Like Greg
He is
Hicks.
an owl, yes.
Okay.
So they're fighting.
Yeah.
Okay, thank you.
Good.
On theme, as you know, the Firefly Project is a piece of the Cancer Center's Art for Recovery program, and Cindy Perlis and the team has been kind enough to continually invite our interns to partake in this important and meaningful program. 54 heartfelt letters exchanged between pen pal partners, thoughtful, personal, unhurried, for patients really navigating this challenging season of life. The connection cultivated here is not a small thing. So thank you to the Firefly Project, and we're excited to participate again next year. Marea Verde! In December, our team was on a mission. We went to San Antonio, drawing inspiration from Argentina's Marea Verde Green Wave movement, which reframed abortion as a public health and human rights issue, ultimately leading to its legalization. Laura herself purchased 5,000 scarves, purple and green, to represent the green wave, and we distributed as many as we could all throughout the conference, and of course, hosting our symposium to really bring the conversation to San Antonio.
There are a few left at the BCC.
If you want to start, they're there. Please. We have plenty to pass out as well. This is really has become a symbol within the Latin American community of reproductive rights, persistence, and what's possible when all of us come together. And that's what we did at San Antonio. I was looking for the photo of the scarf on one of someone's dog.
Oh, the dog.
If I find that, I'll circulate that as well. Okay. One of our cornerstones of the internship is the Patient Support Corps, led by Jeff Belcora. It's a support service designed to help patients become informed, prepared, and active participants in their care. Numbers at a glance. We made an impact. Over 1,700 patients guided on recording their appointments. 1,400 helped to submit their questions before walking in the door. 507 patients supported in pre-charting their questions, and 89 patients accompanied by one of our intern note takers. An important resource that we're continuing to prioritize and have as a cornerstone of our internship. Thank you to Jeff and Alondra for your leadership and guidance in this program. All of the reflections, frameworks, and how you invest in all of our interns. There's a slight lag. Learning, contributing, and advancing. Oh. There we go. Okay. Okay, one of the things that I found to be really unique about this program is the exposure to academic medicine and public scholarship, and really the opportunities that mentors extend to our interns, invite them onto teams, and grow in this important area of medicine. As a group, we have attended a total of 16 conferences. We've presented 51 posters, and there are 14 manuscripts in progress. I just want to thank our mentors and our teams for really creating space and seeing the potential in our interns and helping them grow and tap into these opportunities that at this stage in their career they wouldn't have been able to otherwise. Thank you to the staff members who stretch themselves to teach and just continue to train the next generation. What a year that we have had. These slides don't come close to capturing all of the memories and moments. The 130 trips to the OR to collect tissues for Jennifer Rosenblut's organoid study, the 12 days of the clinic, a call back to our holiday skit this past year, the pumpkin carving, the boba runs, the trivia nights, the salsa dancing, the friendships made. What a year. And we want to thank you. I want to thank especially our mentors, staff, and collaborators. None of this is possible without the people in the room, the people on Zoom, and the people who are out there running the clinic. The mentors have opened up their clinics, their labs, their time to really come around these young folks. And so incredibly grateful. Thank you to the staff whose expertise, patience, and daily support create an environment where interns can thrive. And thank you to all of the collaborators who make a space at the table for the interns to participate.
We also want to give a special thank you to the Friends of the BCC. I know many of them joined over Zoom today. They have generously made this program possible year after year. They're not just funding an internship program, but really investing in the future leaders of healthcare who will center compassion, curiosity, and an unwavering commitment to the patient. We also want to thank Amy Babel. Like Laura mentioned, she had created an endowment to make this remarkable cycle of learning, growth, and giving interns gaining skills, becoming exceptional professionals while patients are receiving the support, compassion, care, and guidance that they need most during life's most difficult moments. That is our year in review.
There's one other person that I forgot to thank, but those of you who are new will meet him tomorrow, and that is my husband, Michael. And Michael will be taking all of your photos tomorrow so we can make our sheet, the cheat sheet for the face sheet. So old school Facebook, the sheets of all the interns and the projects they're working on so we can put that in the clinic and throughout everybody's offices. But many thanks to Michael for all the things he supports, the hikes, you guys coming over, invading the house, etc., and always being a gracious host and coming up with fabulous photos for all that. Anyway, most of all, thanks to you guys, the interns, how we are so proud of you, and I hope and know that you must be so proud of yourselves. The most important thing to do is to take a step back and look at where you started. I think one of the things I asked all of you, you'll know from your interview with me, and I said, first thing I said was, if you were to take a year off and you were to look back at the year, what would make you say, wow, this was successful because? Is there anybody here who's finished their year who doesn't feel that this has been a successful year? No. So I think everyone has accomplished what they hoped and more. And you should be so proud of yourselves. We are so proud of you. And for those that you are moving on for the moment, you are going on to spread this philosophy. And as I always say, that you're part of this community that is really thinking about how to be a leader in medicine, how to set the tone, how to create a culture of learning and compassion, not just for your patients, but for each other. Because that's one thing that you'll find, medicine is not always a kind culture. But and wherever you are in that hierarchy, you can change the tone. And you can be the change that you want to believe in and that everybody should believe in. And so that's what we are doing. We're training you to be future leaders in this field, in whatever field you go into in science and medicine. And we thank you for going on this journey with us. And we thank you for being part of the Vortex forever. And we'll see you at Sparking Innovation next year and at the Intern and the hello, goodbye, lunch and pool swim, whatever, tomorrow at 11 down at Woodside. Everyone has directions? Yes. Does everyone have a way to get down there? That's good. I would offer to drive someone, except my car will be full of food. So we will see you tomorrow. Thank you all so much for your attention. What a fantastic day.